Okay, Kavita, whenever you're ready.
Great. Good morning, everybody, and happy fall. We will now convene the P&T committee meeting. I am Kavita Chawla, the chair of the P&T committee. I will read off the name of the participating attendees. So please say here when I call your name. Starting with our P&T committee members, Peter Barquette. Don't see him here yet. Laura Bestie.
Good morning here.
Morning. Michael Corsillis.
Morning here.
Morning. Kevin, I don't think he's here. Greg Hudson.
Hello here.
Hey, Greg. John McKay.
Good morning here.
Good morning. Good to see you. Zoe Taylor.
Here.
Morning. And Christy Weiland.
Hi, here.
Hi. All right. Our healthcare authority members. Nanya Conner.
Good morning.
Morning. Amy Irvin.
She's not here right now.
Immediate. Okay. Elizabeth Poonsellen.
Good morning.
Morning. Donna Sullivan.
Good morning.
Marissa Tabile.
Good morning.
Ryan Takatomo.
Morning, I'm here.
Hi, Ryan. Joy Zarate.
Good morning.
Morning. And then from our Magellan Medicaid Administrator Presenter, we've got Nina Hune. Not,
Good morning
oh,
here.
there she is. Good morning. And then our managed care organization representatives, we have Greg Seamus from Molina, Heidi Goodrich from Molina, Petra Eichelsdorfer from United Healthcare, Omar Daoud from Community Health Plan of Washington, Jeffrey Natividad from Community Health Plan of Washington. And now Nanya will go over the meeting logistics.
Yes, hello again. The committee and presenters can mute and unmute themselves at any time, but please mute yourselves when not speaking so as to limit background noise. Presenters, please share your webcams while presenting. Committee, please share your webcams while discussing and motion considerations. For stakeholder participation, the chair will read the list of stakeholder names who pre-registered to speak. We will unmute you. After the share, we'll ask if there are any other stakeholders. If there are, please raise your hand and we will call upon you and unmute you. You can also use the Q&A box. We will address your questions during the stakeholder time and concerns. The chat for this meeting is muted, so the Q&A box would be the best way to communicate with us if you have any questions. If you did not fill out the stakeholder conflict of interest form, that's okay. Please answer the questions we'll post on the screen. Your 3-minute will start after you have answered the questions. Thank you.
Thank you, Nanya. Okay, so with that, let's get started. I see Marissa, you're up first to go through our Apple Health policy for bone density regulators.
Good morning. This is Marissa. Yes, I will go ahead and start to present. Let me just get my bearings with trying to show my screen. All right. All right. Hopefully you all can see that. I do have bone density regulators, parathyroid hormone analogs showing. If not, just feel free to stop me if you can't see anything or it's not moving as it's intended to. So good morning to you, our board. I will be going through the bone density regulators clinical policies. So just to give you all some background on these policies. So this policy, or these policies, I should say, are a refresh of our current policy that we have listed online. That policy is numbered 30.04.00. And the last time that that policy was updated was in 2019. So it is in need of a refresh. It's been quite some time since we have gone through it and refreshed that policy. So currently the way that the policy is all of the drugs and indications that I'm going to go through here. There is one additional policy that will be presenting in December that is a part of this breakout. We just didn't have time to include it in this review, but currently all of those live in that one policy that we have posted online. So it's very similar to the strategy that we did for the cytokine and CAMs, where we're breaking them out by mechanism of action. So that is really currently the method of how we're doing it for these policies, as well as we've broken them out by their mechanism of action. So we have a parathyroid hormone analog specific policy. I think it's a rank ligand policy, and I think I have to remember the other one, but you'll see all three of them. They're all broken out. Currently, our policy that we have posted online and that we currently use really only addresses the osteoporosis indications. And really, that osteoporosis indication houses like everything in one. It's not specific to really, I guess, the different types of osteoporosis that these drugs in these policies can address. So we have split them out by postmenopausal osteoporosis, male osteoporosis, glucocorticoid-induced osteoporosis. Just to be a little bit more specific, we were finding that it was a little hard to, with the way that the policy is currently live, kind of getting into those nuances of those different osteoporosis indications was getting a little difficult to kind of read between the lines. So we did make them very specific in these policies. And we did also try to keep all the criteria the same across the indication. So if there was overlap in with some of the drugs, like I'm just going to say postmenopausal osteoporosis, for example, we did try to keep that criteria largely the same across all of the different policies if it was applicable. So some of these I might go through rather quickly just because you will have seen that criteria, in a previous policy that I might have presented moments earlier. The criteria should be largely the same. And we did also include the indications where there are some related to cancer and bone metastasis for those specific drugs. So those are now included in these policies if it's appropriate for that drug. And you will also see too at least in this first policy that I'll be presenting, we do have new language that we have included or will start including in our policies about non-preferred brand name drugs. And we do have policies called our non-clinical policies, which we are currently in development for some of some of the other ones, but we do have one right now that is live on our website that we do use called NC001. And that addresses our brand with generic equivalence policy. So if you have a brand and generic product on the market, and we prefer the generic product over the brand, or we want patients to use the generic over the brand, and there's a clinical policy, we will include that language in our policies moving forward. So, and that's only if those products do have those generics available on the market. So you will see some of that in some of these newer policies and the policies here today as well. I don't think we've gone over that in previous policies this year, so I just wanted to make a note of that. So I'll just go ahead and jump right in to the first policy. So this one is the parathyroid hormone analog policy. And this policy really encompasses two drugs, which is abaloparatide and teriparatide, or Tymlos and Forteo are the brand names. The medical necessity language is really the same as what you've seen before. That hasn't changed, with the exception of referencing the non-clinical policies here at the top. So this is really just pointing out, hey, if there's a generic on the market that we want a patient to use, they must first still use that generic product first before they could be eligible for the brand product. I don't have that non-clinical policy pulled up, but there are specific kind of criteria that we have for that. They've had to, I think it's along the lines of, they'd have to try like X amount of manufacturers or the generics, if there is multiple manufacturers of the product, before they can be eligible for the brand. So that's just referencing that here because I believe there are some generics on the market for some of these products. So getting into the criteria specifically, I'm going to start first with the postmenopausal osteoporosis indication. This really applies to Timlos and Forteo. And for this one, we have an age indication, so 18 years of age or older, diagnosis of osteoporosis. 3, the patient is a postmenopausal female. And 4, at least one of the following fracture risk categories is met. So it would be A, presence of fragility fractures of the hip or spine, regardless of bone mineral density, or a T-score less than -2.5 in the lumbar spine, femoral neck, or total hip, or T-score between -1 and -0.5 with a history of recent fragility fracture of proximal humerus, pelvis, or distal forearm, or D, T-score between -1 and -2.5 with a FRAX 10-year probability for major fracture greater than 20% or a hip fracture greater than 3%. So they just need to meet any one of these A, B, C, or D. And 5, the treatment duration has not exceeded a total of 24 months of cumulative use of parathyroid hormone during their lifetime. Or, and this is really just addressing if 6 is addressing if patients need to use teriparatide longer than 24 months. So the patient has received treatment with a parathyroid hormone for more than 24 months during their lifetime, and the patient essentially still remains at having high or very high fracture risk, which is defined as the following. And these are just some examples. They've had a fracture in the past 12 months. They've had a fracture while they've been on osteoporosis therapy, a history of multiple fractures, T-score less than -3, high risk for falls, and a FRAX 10-year probability for major fracture of greater than 30% or hip fracture greater than 4.5%. So they would either need to meet either 5 or 6, and 6 really only applies really for teriparatide. And 7, the medication will not be used in combination with other bone density regulators, so bisphosphonates, raloxifene, and RANKL inhibitors. And 8, a history of at least one of the following. So this is where we're getting into the trial and failure products that we would expect. So it's really just one of these, so A, B, or C, that the patient would need to meet. So 1 preferred AHPDL oral or intravenous bisphosphonate medication that's been ineffective, or it's contraindicated or not tolerated for a minimum trial of 12 months, or at least 1 preferred selective estrogen receptor modulator or SERM has been ineffective, and that minimum trial is 24 months, or they have been treated with denosumab, and that's been ineffective or contraindicated or not tolerated for a minimum trial of 12 months. And if they meet all the criteria, we would approve the request for up to 12 months, unless the total combined duration of parathyroid hormone analog would exceed 2 years. Then we would just go up to whatever that time frame is if it gets up to 24 years. And then for reauthorization, for this one, criteria 7 just continues to be met, so they're not using it in combination with another bone density regulator. And documentation is submitted demonstrating disease stability or positive clinical response with examples that are listed there. For the abaloparatide, if they meet the reauth criteria above, we would approve it for up to 12 months unless the total combined duration of parathyroid hormone analog would exceed 2 years. So if they've gotten approved before for 12 months and then they need it for an additional 12 months, then we would just approve the 12 months. If, for example, we're up to, I'm just making it up, 20 months, or, well, we wouldn't do that. But as long as it doesn't exceed 2 years, that's kind of how that would work. Or we would go up to the 2 years. For teriparatide, if all of the criteria are met, approved for up to 12 months. And we didn't have that same language for abaloparatide because for teriparatide, you can use it beyond 24 months if they're at very high risk. So that's why the language between the two differs. Getting into male osteoporosis, the criteria is still, it's similar, but a little bit different for the postmenopausal and male osteoporosis. So I'll kind of just note the differences between them. The age is still the same, diagnosis of osteoporosis. 3 is different, where the patient is a biological male. 4, the risk categories are still the same for both men and women. 5 and 6 is still the same across both. And then where it gets a little different is 7 is still the same. 8 is different because treatment with at least one preferred AHPDL, oral or IV bisphosphonate medication indicated for male osteoporosis has been ineffective unless all are contraindicated or not tolerated. So this one, we would just expect them to try and fail an oral bisphosphonate, whereas in the female, in postmenopausal osteoporosis, they have a little bit more options, including SERMs, which you may or may not expect to see in those patients. So just the trial and failure is a little bit different. And then here, the reauth criteria is still the same for that. Same for abaloparatide and teriparatide. For glucocorticoid-induced osteoporosis, this indication only applies for teriparatide or Forteo. For this one, still age indication, diagnosis. 3, this is where it's a little bit different. So the patient has a history of or is currently taking sustained systemic glucocorticoid therapy, and the daily dosage equivalent is greater than 5 milligrams of prednisone, and that would be a minimum use of 3 months. The risk fracture categories are still the same as what you've seen in the previous criterias. 5, 6, and 7 is still the same as what you've seen in the last ones. And then for this one, 8, it would just be trial and failure of a oral or IV bisphosphonate. And if all the criteria are met, we would approve it up to 12 months, but not more than 2 years. Not more than 2 years. And then for this one, same with the reauth criteria. It's the same as above. So if they meet all of it, we approve it up to 12 months. For this one, these are the dosage and the quantity limits for the different products, HICPIC coding and background. And then I'll just go through the policies quickly, and then we can ask questions for all 3 at the end if we want. So then the next policy is for rank ligand inhibitors, rank L inhibitors, which is really just denosumab. And those brand names are Prolia and Xgeva. For this one, the postmenopausal osteoporosis, this criteria should be, is the same as what you just saw in the parathyroid hormone, same age, diagnosis, risk categories. Where it is a little different is you don't see C here, which is the treatment with denosumab, because this is a denosumab specific policy. So they would just need to meet A or B, so oral or IV bisphosphonate or a SERM medication. Same thing, authorized up to 12 months. Reauth criteria is pretty much the same as the last policy, and then reauth duration is 12 months. For glucocorticoid-induced osteoporosis, excuse me, this criteria is still the same as well. The only thing that you'll notice that is different between this policy and the parathyroid hormone policy is that the daily dosage equivalent of prednisone is a little bit different than what you saw in the last policy. So in the last policy, it was 5 milligrams, whereas in this policy, it's greater than 7.5 milligrams of prednisone. And that was really based off of the clinical trial that Prolia was approved for. In the Prolia specific clinical trial, their inclusion criteria had patients on a daily dosage equivalent of greater than 7.5 milligrams of prednisone, whereas in the teriparatide, it was 5 milligrams. So that's why you'll see the differences between the two is just really based off of how these drugs were approved and what those daily equivalents of prednisone were. But everything else is still the same, still treatment with trial and failure of an oral or IV bisphosphonate. And the reauth criteria is still the same durations. For this one, For Prolia specifically, this one is for the treatment of bone loss in men with prostate cancer. For this one, age indication 18 or older, the patient has a diagnosis of bone loss or osteoporosis indicated by one or more of the following. So they can have either A, B, C, or D, or they can have multiple presence. I believe this is still the same as what we used for the risk above in the other criteria. So that is still the same. For 3, the patient is currently receiving androgen deprivation therapy, so Leuprolide, Degralex, Relugolix for non-metastatic prostate cancer. And 4, the medication will not be used in combination with denosumab, which is specifically Xgeva. I believe those two have different indications. That's why we listed it there, just to make sure they're not using that Xgeva product while they're taking Prolia. Authorized for 12 months. Same the reauth criteria is that they continue to meet 3 and 4 above. So just making sure that they're still taking ADT therapy and that it won't be used in combination with the other denosumab product, and that they have documentation that they're stable, and reauthorization duration for 12 months. For the treatment of bone loss in women with breast cancer, this applies to Prolia. For this one, it's pretty much the same as above for the treatment of prostate loss in men with prostate cancer. The only thing that's different here is that for these patients, we would expect that they're receiving adjuvant aromatase inhibitor therapy, so anastrozole, letrozole for breast cancer, and same as long as they're not using it in combination with Xgeva. The request will be approved for 12 months, same reauth criteria that you've seen above. For this particular indication, multiple myeloma and bone metastasis from solid tumors, this applies to Xgeva. For Xgeva, the criteria is that the patient is 18 years of age or older. The patient has one of the following. So a diagnosis of multiple myeloma with skeletal related events. So examples of those are radiation to the bone, pathologic fracture, surgery to the bone and spinal cord compression, or they have bone metastasis from solid tumors. So metastatic breast cancer, metastatic castration-resistant prostate cancer, or metastatic lung cancer. And 3, history of failure, contraindication, or intolerance to zoledronic acid. So just that one product. And then 4, medication will not be used in combination with Prolia. This criteria we kept pretty broad just because of the indication. So not very much there. Authorized for 12 months. They still continue to meet 4 above, just not used in combination with Prolia. And then documentation showing disease stability or positive clinical response, 12-month reauth. And this indication is giant cell tumor of bone. This applies to Xgeva. For this one, the patient is 12 years of age or older and skeletally mature. And 2, they have a diagnosis of giant cell tumor of the bone. And so they could either meet A or B. Disease is resectable or surgical resection. Surgical resection is likely to result in severe morbidity, or the disease is recurrent or metastatic. And 3, the medication will not be used in combination with denosumab. 12-month authorization, and then same reauth that you've seen before. For hypercalcemia of malignancy, this applies to Xgeva. For this one, patient is 18 years of age or older, diagnosis of hypercalcemia of malignancy, and they have a baseline corrected serum calcium greater than 12.5 milligram per deciliter. 3, treatment with at least one preferred oral or IV bisphosphonate medication indicated for glucocorticoid-induced osteoporosis has been ineffective unless all are contraindicated or not tolerated. And 4, medication will not be used in combination with Prolia. Same duration, 12 months, and same reauth criteria. here are the dosage and quantity limits for those products. And then I'll go ahead and get into the last policy, which this one is the bone density regulators, sclerostin inhibitors. And there's only one product that this applies to, which is Evenity or romosozumab. For this one, there's really only one indication as well, which is postmenopausal osteoporosis. For this one, the criteria is the same as what you've seen before. Where it's a little bit different is here we have for the treatment. This one is not for number 6. They would have to be treated with all of these products and not just one of them. It can't be like A, B, C, or D. It's A, B, and C. So they have to meet all 3 of these. For this one, one preferred oral or IV bisphosphonate, one preferred selective estrogen receptor modulator, and Prolia. And for this one, it'll be authorized up to a total of 12 months of treatment per lifetime. And for this product, it can't be renewed. It'll only be authorized for up to a total of 12 months of treatment per lifetime. And here are the dosage and quantity limits. And then here are the forms. I'll actually just put one up, but I can open it up now to any questions, any criteria that you want to see. Again, I know I went through that pretty quickly, but I'll go ahead and pause here for the board.
Thank you, Marissa. Let's see. We can start with this one and then our committee, if you can come back on camera as well. So I had a few questions. One was, if you scroll down where it talks about the trial period for 12 months, I think it says.
Yes, for the bisphosphonate
Yeah.
is number 5 here. And we're looking at the pen form. If you want me to go back to the criteria, let me know.
Okay. I guess that's fine because it's also, yeah, it reflects what's in the policy. Did you want to go through this form before I ask my questions?
If anyone, I can go back to the criteria if no one has any questions on these.
So this is Laura. The only question I had was under the treatment in breast cancer and also prostate cancer. There's no option, so they have to be receiving, like in the males, androgen deprivation therapy, and there's no option if they don't tolerate it. That's not stated. So what if same thing with the women if they don't tolerate um, adjuvant aromatase inhibitor therapy? They wouldn't qualify for it, even if they were intolerant, because it doesn't state that.
Excuse me, Mrs. Marissa. I think we just need to add that language in here. Let me see. I think it's up here.
It was the prostate and the breast cancer.
Yeah, right here. We have the language that we use, I think, unless contraindicated, this one. Ineffective unless all are contraindicated or not tolerated. Are you pretty much recommending that we add that in there?
That would be my suggestion because there are some patients that won't tolerate it.
Yeah. So I think I can add that. That was an oversight on our end, but a good call out for sure. Let me. Okay. Oh, let me track this. There we go.
So, Kavita here. So, what we're saying here is if they're not tolerating the treatment or they're at the end of their treatment, right? Like, so for example, for the adjuvant hormone therapy with breast cancer, the usual timeline is about 5 years, maybe sometimes 10 years. So they might have ended that treatment. But at the same time, denosumab can be stopped. right? Like there is no endpoint to denosumab because if you stop denosumab and don't convert over to either a bisphosphonate or some other like a raloxifene, you will lose all of the bone density and you will be at risk for high risk for fragility fractures. So uh, how do we accommodate for that in the criteria here? Does that question make sense? That they will at some point in their hormone therapy, but they cannot stop denosumab for life unless converting.
This is Marissa. I think I understand what you're saying. I'm trying to think of a way how we could add that type of language in here. That might be something that I need to think about. I'm not good at thinking about it on the fly or
Sure,
creating
sure.
things on
No,
the fly.
Is there
no, that's
any way
totally fair.
like
Mhm.
for renewals, like sometimes some it seems like some drugs like there's never a problem with just continuing it, and some drugs it's really hard to get approved even if you're continuing it. I wonder if there's a way to make it like some sort of process where if you're continuing it, we don't have to deal with any of this.
This is Marissa.
I wonder if it could be, because I do realize the price point for denosumab is crazy. So I do understand why there's a pre-auth on it. But at the same time, I wonder if there's some language in here that can be said, if um, if basically if no if bisphosphonates cannot be tolerated or are contraindicated, then that is one of the criteria for reauthorizing it. Does that make sense? Because like again, there's nothing else for them to transition to from denosumab. If they are on hormone therapy, I don't think they can go on to raloxifene long term. Um, Someone better than me in oncology might be able to answer that, but my understanding is after that, that you don't have any other options left if you can't tolerate bisphosphonates.
This is Christy Weiland. What if under reauthorization criteria, because it says you must meet criteria 3 and 4, if
Mhm.
that language changed to, criteria 3 or history, right? And then +4, because that would allow for them to either be on current therapy, right, or history of.
I like that. Yeah.
This is Marissa. Let me see. Criteria 3.
So I think Kavita here, I think Christy's saying in the bullet point 3, right, Christy?
I was actually saying reauthorization, because if they're in that first year, I would suspect they would be in current therapy. So if it's being reauthorized, that's where we would know that they had, the history of, and they might be done with therapy.
Mm.
And so rather than them having to meet criteria 3, specifically, we could say they had met criteria 3 and they still need to meet criteria 4.
I think this is Marissa. I think maybe in that case, we can just consider removing criteria 3 from here, and then it would just be that criteria 4 continues to be met. And then they would just need the documentation that they're stable.
Mhm, mhm.
So we could do that. Let me do this the simple way so it looks
Yeah,
cleaner. There you go.
This
that's
is Laura. Do we have to state that they can't tolerate bisphosphonates too with that though? Because usually you would switch to a bisphosphonate to maintain bone density after discontinuation.
Hey, this is Marissa. Can you repeat that question one more time, Laura? Sorry.
So once again, I'm not oncology, but once you discontinue uh, denosumab, then you would, if the patient can tolerate bisphosphonates, it looks like the recommended therapy is to continue with bisphosphonates to maintain the bone density. So when we have to state in there somewhere for reauthorization that they cannot tolerate bisphosphonates.
Kavita here. I get what you're saying, Laura, and I almost wonder if that actually needs to be in the authorization part to begin with, to even allow patients to get on denosumab. We say that the patient cannot tolerate or bisphosphonates are contraindicated, even for the initial authorization.
This is Marissa. That's what I was thinking too. Kavita was that might be more appropriate up in the initial.
Yeah, I do think that that's an important call out up front because once you get on that train, can't get off.
So I can add that.
And yeah, and that probably would be true for authorization for pretty much, yeah, all of them.
Would you, is the DUR board recommending also that I add that for the prostate cancer indication as well? I would think
Yeah.
yes.
This
I
was
don't want to assume.
yes, no, I
Okay.
appreciate this.
Okay. And I'm going to add it here.
This is Chrissy Wyland. Just to clarify, is this going to mean that a patient has to be continuing a bisphosphonate and cannot switch over to denosumab, and even if they don't have clinical stability with a bisphosphonate? Is that gonna, like, if they continue to worsen, I fear that the language we're putting in is going to continue them to use a bisphosphonate and not allow that to transition over with disease progression.
Kavita here. Yeah, I see what you're saying. I guess what I wonder about that is it is from all of the studies is I'm not aware of any study that shows that denosumab does better than bisphosphonates in any scenario. So if we are what I've ever seen, if a patient's ever being transitioned to denosumab, it is because either chronic kidney disease or they can't tolerate the side effects of the bisphosphonate, but it would never be for lower clinical efficacy. But I might be wrong if someone knows.
Yeah, I have one patient on denosumab, and it was because I did a consult with a rheumatologist who specializes in osteoporosis, and because her T-score was like minus 3.5 or something, she said that because it was so severe, it would be better to use it. And like maybe that's just expert opinion, but I
Yeah.
don't think that the insurance rules should get in the way of that. So like what we want to avoid is like the primary care doctor having to fill out a million papers and jump through a million hoops when it's indicated. So just be careful about being too specific about, there's all sorts of different clinical scenarios.
Yeah, Kavita here, totally agree. I guess, and yes, we probably don't want to have like a clinical debate here, but I would say that when T-score is that severe, all the more reason that you would first go with an anabolic and then a bisphosphonate rather than going to denosumab because there are just so many issues and you can see that in all of the recent guidelines in the past 3 years that have been published that have called out problems with denosumab. And so while it was the savior when it initially came out, we're now seeing 10 years later so many problems with it.
Okay.
The biggest one being when they can't make it to that 6-month shot and then they're suffering from these fragility fractures. So this is one of those rare scenarios where I like if where insurance puts in some barriers to easily accessing a medication that not all clinicians may be up to speed with and like continue to just prescribe it, thereby not protecting patients, if that makes sense. But I don't know if that's so yeah.
I mean, but you also wouldn't want the insurance to be the reason the patient misses the shot, right? So
Yeah.
that's the hard
This
thing.
is John McKay here. Kavita, I kind of echo your opinion too in terms of like anabolic therapy and severe osteoporosis. I was hoping that we could maybe revisit the criteria for like the anabolic agents,
Yeah.
Forteo, Timlos, and Avinity. Sometimes, if there's a fragility fracture with moderate osteoporosis or a severe osteoporosis with a T-score -3, it'd be clinically appropriate to go right to anabolic agent. I don't think it would be appropriate to stay on like an anti-resorptive Prolia or a bisphosphonate. So I think in terms of requiring somebody, especially like a SERM, not very clinically efficacious, but I would probably jump right to an anabolic agent like Tymlos or Forteo or Avinity if there's a history of multiple vertebral fractures, regardless of their T score, or if they have a less than minus T or three T score. So I don't know if the committee has any opinions on that.
Yeah, Kavita here. I definitely second that. And in fact, there's studies that have shown that for bisphosphonate naive patients, if you put them on an anabolic treatment first and then do bisphosphonates, they have way higher bone density buildup than starting with bisphosphonates and then trying to add an anabolic. So, yeah, no, I completely echo what you're saying, John. So I know we are jumping back and forth, Marissa, between the two policies. I don't know if you want to resolve one and then go to the other or how you want to do it. Sorry.
Marissa. Oh no, that's fine. I guess we'll go back to the cancer and then we can go back to the anabolic.
Okay.
Since these particular indications don't really have crossover in the others. But if we do decide to change anything in the parathyroid, then I can just apply it across all the policies if we do decide to make any changes. So I believe where we left off was requiring, I think Kavita, you were recommending adding the step through the oral or bisphosphonate before they could be eligible for Prolia, unless of course it's contraindicated or not tolerated.
Yeah. And this is just a typing thing. I do see the glucocorticoid-induced osteoporosis is being carried over
Oh yeah,
in all of the paragraphs. I think I saw that in the hypercalcemia of malignancy as well.
I would also maybe just move this minimum trial of 12 months parenthetical to after the word has been effective. Because the way it reads right now, it seems like you'd have to try it for 12 months, even if it was not tolerated, which I don't think is the intention. Like if it's to determine it's ineffective, there's a minimum of 12 months, but not to determine that it's not tolerated.
I see what you're saying. Let me think about how we do that because that's just our standard for how we've done that in the past, but I can consider moving that.
Okay.
Yeah, for the other ones, but I see what you're saying for sure.
This is Laura. Could you word it at the beginning of the sentence? Minimum trial of treatment with at least one preferred has been ineffective unless contraindicated, not tolerated.
This is Marissa. Sorry, can you repeat that one more time? I was trying to type and listen at the same time. Minimum trial. Is that what you were saying? Hopefully I didn't butcher that.
What do you think, Zoe?
Yeah.
Reasonable? Yeah, I agree. And then when we say, sorry, Kavita Chawla, when we say ineffective, are we saying, or actually one of the requirements is for reauthorization that they are demonstrating stability? Is that to say that they need a bone density scan every year or just a lack of a fracture? Or what is it that we want a clinician to document to demonstrate stability?
This is Marissa. So that we've kind of put like examples. So we have here that they haven't suffered. So if the doctor notes that they haven't had a fragility fracture, or if their bone mineral density continues to improve or remain stable, those are just some examples that we came up with. But if there's other clinical examples, those are just the ones I could think of, that you can think of, then I can definitely add those in. But
Yeah,
those are
no,
kind of what you were alluding to, or what the examples that you listed were what we would be looking for.
I just don't think that that should be required because I think it's too hard to prove and it's like not realistic.
This is Marissa. Zoe, sorry, I didn't hear you. Can you
Like
repeat that?
after 12 months, you just like wouldn't necessarily have any proof of that. And I wouldn't go out of my way in a note to specifically write that they didn't have a fragility fracture. So I just worry that this is just a way that it would get denied when it shouldn't be.
Well, we include language like that just so that then in the chart notes we can see, because how would we be able to see that a patient is either not progressing on therapy or having a clinical
But
history?
if somebody had a fragility fracture after being on 12 months of denosumab, would we want the patient to stop it?
I think the idea, Kavita here, I think the idea there would be that fragility fracture indicates that they would probably need to transition to an anabolic treatment, at
Which
least.
is something that the provider can decide, right? It's not something that the insurance company needs to force on the provider, right? Like, why
Um,
would it be denied just because it hasn't been? I don't know. It doesn't really make sense to me.
And I had a quick comment. This is John McKay here to the criteria. I mean, it's kind of the standard of care for the bone mineral density every 2 years. I mean, sometimes more often, but if we're looking at this annually, are you going to have a DEXA to review every year?
You won't.
And this is Marissa, these examples that we provided, like if there are other examples or other kind of notes that the provider puts in the notes saying that they are stable or that they are responding to therapy, then we would definitely take that into consideration. These are not like hard set, they have to have a bone mineral density scan every year. It's just kind of examples of what we would accept. So I just want to caveat that by saying, as long as there's some type of, note in the chart notes, as long as there's some kind of documentation in the chart notes saying that they're responding well to therapy, that they are stable on the medication, then, however that's worded, however all providers word it differently, when we are looking at the chart notes, then we would take that into consideration and accept it if we think if it clinically meets what we are looking for.
This is Peter. I think kind of what's going on here is if a medication isn't having its intended effect, you're not getting the benefit of the medication. However, you may still get the risks of the side effects. And patients don't always show up saying like, "Hey, I had a fragility fracture." And I've seen this in my practice where until something happens with the insurance company, that like I don't realize that they had a fracture last month and have been seeing orthopedics. But if I get some kind of flag, whether it's a denial of a medication or some kind of outreach about HCC coding or something like that, that can be actually a trigger to make sure the patient's on appropriate care. Personally, I think it's reasonable to have it in the way that this is written, and I think that's the way a lot of health plans actually write their criteria. I'm okay with it. I definitely understand John's point. Like most of the time, you're not going to have the DEXA scan within a couple of years, but definitely if somebody had a fragility fracture, then it would indicate probably this isn't the best treatment, and that the fact that prolongation or continuation of a medicine that doesn't seem to be working like would get denied actually would be a good trigger for both the patient and the prescribed clinician to reevaluate treatment. I'm okay with it.
Fair.
And this is Laura. It does say examples, so it's not requiring it.
Is it standard that you have to submit chart notes for continuation of a medication like always?
This is Marissa.
That is like a burden, you know?
This is Marissa. Usually, yes, for reauthorizations, we typically do require chart notes. I believe in the pen forms, we do have, let me double check. Yeah, we do have at the bottom that the chart notes are required with the request. So usually standard for most of the requests, we do require chart notes. There are some where maybe we won't, whether or not we have that programmed, specifically in our system to do like electronic PAs or whatnot. That's not really working right now. But in most cases, yes.
Okay. Yeah, it's probably fine. I'm just trying to be the voice of, reducing clinician burden every meeting.
We totally understand, that it is a burden for providers to submit that documentation. We just want, on our end, as the healthcare authority kind of going through these requests, just making sure we're doing our due diligence to make sure that, it is being, prescribed for the right things, that we, any monitoring that we need to do, that we do see that. So that's why we usually require the chart notes, just to make sure.
Yeah, Kavita here. I agree. And I mean, for that, I even have history of fragility fracture is like part of my osteoporosis follow-up template for my patients. So I agree with the way it's written as well. Is there any other discussion from, I guess, the committee for this one before we jump over to the anabolic treatments?
And this is Marissa. I just wanted to point out to the board that I am adding the trial and failure of a oral or IV bisphosphonate for the prostate cancer and for the breast cancer for Prolia. So I have added that here in number 5. And this we will consider striking out. I added it here, but we may go back as HCA and maybe talk about how we could better word that as well, where it's like shows the ineffective trial is the 12 months. So just wanted to point that out, but I definitely noted that here.
Thank you. And Kavita here, Marissa, as we're going through this, are there any requirements for coverage of raloxifene for osteoporosis?
This is Marissa. No, to my knowledge, raloxifene is preferred without PA on our AHPDL.
Okay, all right.
Yeah, and I believe the bisphosphonates are as well. We have some preferred without PA.
Thank you. Okay, so then we can look at the anabolics, both the PDAH analogs and then the romosozumab.
And this is Marissa. This is the post-menopausal osteoporosis criteria that I'm showing here. So if you wanted me to change, if you wanted to look at another one, just let me know.
This is Laura. I think once again, if we want to change the verbiage on the 12 months trial to the beginning from the end.
Kavita here. I think this is the part, John, that you were speaking to, that we should not require a history of SERM or bisphosphonates if the patient is starting out with severe osteoporosis or multiple fragility fractures.
Yeah, correct. John here. So I think it's just important to recognize that it would be clinically appropriate to jump to an anti-resorptive in certain cases. So in terms of like moderate osteoporosis with a fragility fracture, or multiple vertebral fractures, or fragility fractures, regardless of T-score, or severe osteoporosis. So I think that we should just recognize that.
Kavita here. So in terms of wording it, it seems like history of at least one of the following. So maybe that we could add a D on there that the patient has had severe osteoporosis with a T-score of -3 or multiple fragility fractures, or I don't know, just fragility, yeah, two more fragility fractures, something like that, John?
I think that would be great. Or maybe in addition, like a moderate osteoporosis less than -2.5 with a fragility fracture as
What
well.
does criteria 6 say though? Because it sounds pretty similar.
Sorry, so your voice is distant.
Oh, I'm
Yeah,
sorry. Let me try.
Yeah, that's
there you go.
better.
You sound better.
Yeah, that's better.
Can you hear me now?
Yeah.
Okay. Because 6 says something similar to that, so I just wanted us to reconcile those. Like we could copy the same criteria that it says in 6 instead of having it be slightly different. Like if it says less than 3 and multiple fractures. Or we could make it different, either way.
Yeah, Kavita here, I think that might be tricky only because it says if the patient has very high fracture risk. So if we just said that, and then I think those are just examples of documentation, that might encompass too many patients for
Fair.
using anabolics as first line.
Okay.
This is Marissa. So sorry, I think I might have missed
No.
what Kavita and John were saying.
So I think yes. So in D, it can say so T score less than equal to -2.5 with fragility fractures. John, I'll let you take over.
Yep, so I think T-score of less than -2.5 with a fragility fracture. History of multiple fragility fractures, regardless of T-score, or T-score of less than -3.
All right, so T-score less than -2.5 with a fragility fracture, history of multiple fragility fractures. I'm sorry, I was trying to type it listen.
Or a T-score of less than -3. I'm not remembering my guidelines very well.
I think you're spot on.
This is Marissa. Hopefully I captured that correctly.
I guess just for all of those, I would say less than equal to sign.
Mhm. Nope. I don't know the shortcut to insert that. So if anyone has any tips on how to do that, let me know because I always have to go to the symbol.
And this is Laura for standards for it shouldn't have a trailing zero, so just make it -3. Get rid of your dot zero. There you go.
This is Marissa. I'm just going to see if the risk up here. So we have 2.5 with fragility fracture or multiple fractures and T-score of -3. Less than me. Okay, I see. The intent, this is Marissa, the intent of D is that, just so that I'm understanding correctly, is that the abaloparatide or teriparatide would be used first line, correct?
Correct.
Okay. I'm trying to think of some language that we might want to put in addition to this, like in this sentence, so that then for the clinical reviewer, they know that that's the intent. So let me,
Would it be something, Kavita here, would it be something like this, and this, indicating severe osteoporosis, which would warrant first-line anabolic treatment, something like that?
yeah, I was thinking something saying like that it would be used first line.
This is John here, or regardless of previous therapy.
I think that might address the need. Hopefully what I added doesn't make that more confusing. I'm just trying to differentiate between that. These should be, it would be defined as a T-score less than negative 2.5 or history of multiple fragility fractures or a T-score of -3, right? Okay. Sorry, this gets kind of just so that then, and I might have to take this back. I don't want you all watching me wordsmith can get kind of this is Marissa. I did a little bit of, got a little bit more specific. Let me know if you all like that, if you don't like that, if it meets the need, I can change it.
This is Laura. The only comment I would have is it says will be used first line. I think I would change that to maybe or could
Can
be considered to be first line. I don't know, however you want to word it.
can be used first line.
Yeah.
You might even consider inversing the order of the phrase there to say something like teriparatide and blah, blah, blah may be considered medically necessary for first-line therapy in patients with severe osteoporosis as defined by one of the following, and then 1, 2, 3.
I like that. Um, yeah. Can you repeat that one more time, Peter? I'm sorry.
Yeah, I think it was like maybe considered medically necessary for first-line therapy of severe osteoporosis as defined by one of the following.
Okay. I think we may have landed somewhere. Okay.
Yay, great job, team.
So abaloparatide or paratide may be considered medically necessary for first-line therapy for severe osteoporosis defined as. There we go. This is Marissa. So this was in the post-menopausal osteoporosis section. The DUR board recommending that I add it to all the indications that are listed here in this policy as well. This
So,
and criteria D specifically.
so I see male osteoporosis. Which were the other indications? I would agree with.
So we have male osteoporosis. Apologize for the scrolling. Glucocorticoid-induced osteoporosis, and that's it. Just those three.
I would agree with male osteoporosis, I guess. I mean, it makes sense also for the glucocorticoid induced, but I don't know if anybody else.
I think so, just because I have patients where it's like both, and I might have coded it as glucocorticoid if I feel like that's the main reason, but they're also postmenopausal. So I feel like it probably makes sense to put it on all of them.
Marissa. That's what I was thinking. So I can put it.
This has been super helpful for me though, because I guess when I did that consult a couple years ago, I think the main reason that she didn't recommend this was because of insurance, like not covering it. So I guess it's good to know that if we can make a difference to make it easier to get teriparatide and it's better than Prolia, then maybe that'll actually push people, convince people that it's not actually so hard to get that it's not worth trying, if that makes sense. I mean, I think the adherence issue is also still an issue, right? Like it's way easier to get something every 6 months than do it every day. But yeah.
This is Marissa. So I believe I added it to all of them. So I think we should be good.
This is Kavita. I just looked up the guidelines super quick, and it is recommended the same. PTH analogs should be used as first line if they have severe osteoporosis. Even before initiating glucocorticoids, by the way.
This is John here. I was just wondering too if we should look at Ramosumab as well for the criteria. I understand like the expense is probably prohibitive and compared to the PTH analogs, but there might be a place in therapy for that as well.
This is Marissa. Yeah. Let me just double check for this policy. Is there any other comments or anything that we wanted to add? Okay. I'm going to save this real quick all of our beautiful work. And then let me go ahead. And I believe I made a change to the other one. Let me just make sure I'm saving all of these. And then I will move to the one that John just mentioned, which is the romosozumab. All right, and this is just the one criteria here.
Kavita here. I guess the only so yeah, if you I think we're talking about point number 6. Treatment with all of these has been ineffective. I would not require a patient to go through all of them necessarily if they're meeting those criteria again for first-line treatment. But I guess a question for the committee is, as best as I know, it's mixed results in terms of comparing romosozumab with PTH analogs. And so should we, because PTH analog, I don't know if those are cheaper, but they definitely have been around longer, so we know their side effect profile better. Should we include anything on here that PTH analogs should at least be tried before romosozumab?
This is John here. I think that would be appropriate. I think there are some cases where like a avidity might be preferred, like parathyroid hormone disorders or like hypercalcemia or history of kidney stones. I do think like there are some cases where going right to avidity would be preferred.
This is Marissa's. So John, are you proposing anything for 6? Did you want to make a proposal for any changes?
Kavita, do you recommend parathyroid hormone analogs first and then romosozumab second, unless it's not clinically appropriate or contraindicated? Is
Yeah.
that what would you recommend?
Yeah, those are my thoughts.
Okay. I would agree with that.
So I guess, yeah, so the D becomes that same D from the other one, but with a trial of, I'm getting the committee's help here in wordsmithing again, as you do, Marissa, like how do we include in here? So Belleville may be considered, so we use this. And then say if these are not tolerated or contraindicated, then romosozumab. Does that make sense, Marissa?
This is Marissa. So essentially, we would switch these, and I'll do a mock-up of what that would look like.
This is Laura. There's a typo there too. There should be ABALO, not LAO.
Oh, and this only applies. Let me actually change this.
I think it's just that one.
This actually, because it doesn't apply to everything. Okay. No. So I think what I hear you saying, Kavita, is this would be, let me change. I can spell. Romosozumab. I think that's a Q. A-Q-Q-G. Can't tell with the red. U-G. Like that, I think, is what I heard. What I think you were trying to convey.
Yeah, I guess so. Maybe consider medically necessary for first line therapy for severe osteoporosis defined as one of the following, and PDH analogs are not tolerated or contraindicated.
Um,
So that's the wordsmithing part. Does that make sense what we're proposing?
oh, I see what you're saying. This is Marissa. For the DUR board, you're recommending just for the severe osteoporosis that they step through the the
PDH analogs?
yes, yeah. Is that correct? Just severe.
Yeah.
Okay.
Yes, I would concur with that.
For severe osteoporosis, if PDH analogs are contraindicated or not tolerated, period. And then you would say severe osteoporosis defined as. What does the committee think about that? Does that look okay? I see some nodding. Yeah.
This is John again here. So in terms of the 12-month limit per lifetime, I think 12 months is like the limit of duration of therapy, but I don't know that sequential therapy is contraindicated. I mean, it's probably more inconsequential in terms of the number of patients, but I don't know that you can get 12 months per per series of doses, but you can get more than one series per lifetime, as far as I'm aware.
Yeah, Kavita here, I don't know enough about vanity. I don't think it's been out long enough to really know long term that kind of going back and forth kind of stuff. So it was Marissa, do you know if that was just derived from the FDA approval? Does the FDA approval say something about 12 months per lifetime?
This is Marissa. This I got exactly from, I can double check.
This is Laura. I have it up that the anabolic effects of romosozumab wanes after 12 monthly doses. Therefore, duration should be limited to 12-month doses. If osteoporosis therapy continued therapy with anti-resorptive agents should be considered. I've always heard that it's just 12 months only too.
I guess, yeah, Kavita here, I'm looking at Evanity's website and they're saying it's taken for just 12 months. So would that be okay to leave it there, John, you think, for now?
Yeah, I think that the data is newer data that in terms of sequential therapy where you would step down and step back up again in the future. So there's probably not enough published data, but Yeah, I'm okay with that at this time.
Yeah, I think in the absence of data showing safety, I would err on the side of being conservative. I think everybody got surprised, however many years ago when we started to see fertility fractures with more than 7 years of bisphosphonate therapy. We can always come back and change this policy if it becomes clear that it's safe to take it again.
Great, that sounds good. Any other edits on the policies committee? I'm very proud of our work here today on this. And then if not, we can look at the final policies and the motions to approve them.
Okay, this is Marissa. Let me go ahead and pull up policies. Okay, so these are 3 different motions for all of them. And let me just make sure I save everything.
This is Laura. Do we need to look at the form that needs to be checked off to make sure it matches what we just decided on, or will that change accordingly?
This is Marissa. So usually when we make changes, we do have our operations team go back because they do compare before the meeting and after the meeting, and then they do make the updates to make sure that it does match. Yeah. So we'll make sure on our end that it matches what you all recommended. I can go back to the forms though, if you just want to do your due diligence and look at them. Would that be helpful?
Kavita here. Yeah, let's just look at
Okay.
it. Assume that the changes that we made this morning will get reflected, but just making sure there's no other confusing language on there from a clinician standpoint.
So this one is for the parathyroid hormone form.
Okay.
I think here is where we would probably add if they have severe fracture.
Mhm.
Somewhere here, we would add that either 4 or 5 to make sure. And then this is for teriparatide.
Kavita here, just, using, okay, it's a question for the committee because I don't really know if it belongs here, but we know that the number one reason for treatment failure on any of these medications often tends to be patients actually just not getting enough calcium and vitamin D. And I know that Medicare requires, especially for things like denosumab, they will require that we document the patients are getting adequate amounts, not necessarily testing. But at the same time, clinician burnout, as Oya said, and so I don't want to add additional barriers. Is there any kind of framework or guardrails we want to put in here? If the patient suffers a fragility fracture, that we're making sure that's being checked, or that's too much in the clinical realm, and so we don't need to add language here.
This is Marissa. So Kavita, when I was drafting the policy, I was going back and forth of whether or not I should add, like patient will be on sufficient, and I'm making this up on the fly, but something along the lines of that they'll be on adequate calcium and vitamin D supplementation. I did go back and forth on that. And I erred more on the side of not including it, just because one, I think it might have added another kind of layer. And then 2, we do cover vitamin D products and calcium products on our PDL. But sometimes there can be issues with rebating and things like that, and just claims processing things that we have issues with. So I didn't want to include all of that yet if it's not completely we are kind of having issues right now with our PDL with some of those products. So that's kind of why I erred on the side of not including it. With
Kavita,
the expectation that clinicians would be still, prescribing those things in good practice.
This is John here. So Kavita, I think that's a good point. But we do for like some of our endo patients, we do hold calcium supplementation if they have like hypercalciuria. And so we do let there are cases where we occasionally like hold calcium supplements. So
Yeah, totally agree, Kavita here. Yeah, it's usually our emphasis is calcium from diet and not supplements because of all of those problems. Okay, it's fuzzy enough that we won't really include that in the policy and cause confusion. Okay. Any other comments about this form before we look at the motions from the committee?
This is Marissa. I'll go ahead and show the rank ligand inhibitors form. I don't think I've shown that one. Keeping in mind that we would probably add, like I mentioned, the severe fractures somewhere in Form 5 is what I'm envisioning. And I think the IV bisphosphonate for the cancer would probably be somewhere here. It looks like it is already, but we'll make sure that oh, here we go. Oh, here we would add that. And then I'll move over to the last one, which is the romosozumab form, very short, luckily. And we would add that same severe osteoporosis, probably in 4 or 5 here.
Kavita here. I seem to recall that in previous forms we have also included contraindications. For example, in this one, I think you've said, if they're on another treatment, don't put them on like 2 anti-resorptive treatments. Should we be including CKD as a contraindication, or does the patient have CKD stage 3 or higher on the bisphosphonates form? It's more like a prompt for the provider to make sure they're getting an updated serum creatinine before they, do an infusion with zoledronic acid, something like that.
I would say if you wanted to do that, we probably should add that maybe to the criteria just so that then it'll trigger that that's something that would get added to the pen form. So I would recommend adding that one to the criteria. That way it can get added here to the form. Because if we'd want to see the labs, I'm sure us as the pharmacists want to see them as well.
What does the committee think about the CKD criteria? Should we be including that for bisphosphonates?
I think the trickiest thing is it doesn't actually fall neatly to CKD like 3A or 3B, right? Isn't it? It's a creatinine clearance, not GFR, and it's 35, right? I could look it up.
You adjust it.
Sorry.
Oh, you're talking about for dosing, not for contraindications?
Oh, sorry. I was talking about contraindications.
Yeah, so I think like generally, right, isn't it? It's creatinine clearance, and if your creatinine clearance is less than 35, then if you go to denosumab, unless it's less than 30, and then you'd stop. I'm gonna look it up.
Yeah, Kavita here, I believe is 35 for the eGFR.
Yeah, I'm looking it up now. It's creatinine clearance less than 35. So which doesn't necessarily correlate to eGFR.
And maybe that's something that, I don't know. Do we, I guess the question is for Marissa then, like, is that for patients that do need to be renally dosed or are contraindicated if there's a renal failure, liver failure, that kind of stuff? Do you usually include that on the policy or not necessarily? Because if we don't usually do that, we don't need to start doing it for bisphosphonates.
I would say traditionally in the policies that we've written, we have not. But it could be now that you mention it, a good monitoring. We try to, if it's not like a complete contraindication, then we tend to kind of keep them off, like measures like that. Yeah. labs.
Okay. So I think if that's not, if the absolute contraindications are not typically included, then we can leave it alone and we can just go to the policy.
This is Marissa. Sorry, Kavita, did you want me to show the policy or are we good with the form?
Well, sorry. Yes, we're good with the form. We can proceed with the motions.
Oh, okay. Sounds good.
Guess I'll get started. I'm Kavita here. I'm Kavita Chawla. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 30.04.40-2 as recommended.
This is Laura Bestie. I second the motion.
All in favor, please say aye.
Aye.
Any opposed or abstain? Okay, the motion carries.
This is Christy Weiland. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 30.04.45-2 as recommended.
Second.
John
Is it-
McKay, second.
I'm sorry.
All in favor, please say aye.
Aye.
Any opposed or abstain? Great, and the motion carries.
I can take this one. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 30.04.48-2 as recommended.
This is Zoe Taylor, and I second.
All in favor, please say aye.
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 Any opposed or abstain? Great, and the motion carries.
Perfect. Thank you so much, DUR board. I have made sure that I saved everything. And thank you so much for a very thoughtful and insightful conversation. I definitely appreciate your feedback. So I will go ahead and stop sharing. And I think we
Good
have
job.
drug class
Great.
reviews now.
Thank you. Okay, so on the schedule, I see Nina is up next to go over the antihyperlipidemics.
Yes. Marissa, are you gonna pull that up for me?
Marissa, yes. Let me just make sure I'm saving everything one more time. I do not want to lose any of this work. And then I will pull your slides up in just a minute.
Okay, thank you.
I appreciate everyone's patience as I try to pull everything up. Okay. Let me get your slide. All right, and I did just want to note for the DUR board that if you don't already know, so Magellan has actually undergone a change where now they are called Prime Therapeutics. So moving forward, we are trying to change everything that we have that is Magellan branded, whether that be on the agenda, the website, everything like that. You will notice that the slides do have Prime Therapeutics now. So if you're wondering why Nina is now Prime, it's because Magellan has gone through a rebrand. So moving forward, we will be referencing them as Prime. We are trying our best to make sure that everything gets changed over to their new name. So just wanted to put that note out there for you all in case you get confused. So let me pull up your slides, Nina. And we should be good to go. So
right.
hopefully you can all see it.
Okay, hello, you are bored. This is Nina Nguyen, again from Prime Therapeutics. Thanks for the background information, Marissa, on that. And I will be going over a few topics for today's agenda. So for today's agenda topics for the classes that will be reviewed, I will be going over the disease states, any new updates from the past year, including guidelines, indication, dosages, and formulations. Okay, on the top in dark purple is the Prime Therapeutic Market Basket classes, and listed below that in light purple is the Apple Health drug classes. So our first agenda topic will be antihyperlipidemics, adenosine triphosphate citrate lyase inhibitors, angiopoietin-like protein inhibitors, macrosomal triglyceride transfer protein (MTP) inhibitor, and PCSK9 inhibitors. Okay, cardiovascular is our first disease state. So many clinical trials have demonstrated that high serum concentration of low density lipoprotein cholesterol, LDLC, and low level of high density lipoprotein cholesterol, HDLC, are major risk factors for coronary heart disease. The National Health and Nutrition Examination Surveys (NHANES) reported that in 2015 to 2018, approximately 11.4% of adults in the United States had high total cholesterol and 17.2% had low HDLC. The prevalence of elevated total cholesterol was higher in women compared to men, but the difference was not significant. The prevalence of low HDLC was higher in men compared to women, and in 2015 to 2018, there were no significant race or Hispanic origin differences in the prevalence of high total cholesterol in adults. The NHANES analysis was based on measured cholesterol only and did not consider whether lipid-lowering medications were taken. Okay. Between 2013 and 2019, the American College of Cardiology (ACC) and the American Heart Association (AHA), in combination with the National Heart, Lung, and Blood Institute (NHLBI), released four new consensus guidelines regarding cholesterol management, cardiovascular risk assessment, obesity, and lifestyle. ACC/AHA emphasizes lifestyle modification, including a reduced calorie diet and aerobic physical activity, as a critical component of atherosclerotic cardiovascular disease risk reduction, both prior to and in conjunction with cholesterol-lowering drug therapies. In June 2021, the AHA published a scientific statement on physical activity as a crucial component in the first-line treatment for increased blood pressure and cholesterol. The statement details mild to moderate risk patient groups appropriate for lifestyle-only treatment of increased cholesterol, as well as descriptions of the recommendations, usual effects, and considerations for lifestyle management with physical activity. Guidance and resources were also provided for evaluating, prescribing, counseling, and referring to assist in increased physical activity. In 2023, the AHA published a scientific statement which reports that resistant training has a favorable but modest effect on total cholesterol, triglycerides, and HDL. Evidence for the effect of resistant training on LDL cholesterol is more variable. In March 2024, a new indication was approved for Praluent alirocumab. It was FDA approved for adjunct to diet and other LDL cholesterol lowering therapies in pediatrics at least 8 years old with heterozygous familial hypercholesterolemia to reduce LDL. The recommended dose is stratified by indication, age, and weight. For the new indication in pediatric patients less than 50 kilograms, the recommended dose is 150 milligrams sub-Q every 4 weeks. And if LDL lowering cholesterol lowering response is inadequate, we will adjust the dose to 75 milligrams sub-Q every 2 weeks. For patients at least 50 kilogram and above, the recommended dose is 300 milligrams sub-Q every 4 weeks. And if LDL cholesterol lowering response is inadequate, we'll adjust the dose to 150 milligrams sub-Q every 2 weeks. LDL cholesterol lowering effect can be measured as early as 4 weeks after initiation, and a caregiver should administer treatment for pediatric patients between age 8 to 11 years old. Next, we have Nexletol and Nexlizet. So in March 2024, a new indication was approved for Nexletol, bempedoic acid, and Nexlizet, which is a combination of bempedoic acid with ezetimibe. It was FDA approved to reduce the risk of MI and coronary revascularization in adults who are unable to take recommended statin therapy, including those not taking a statin, with one established cardiovascular disease, which I will refer to CVD, and a high risk for a CVD event, but without established CVD. The Nexletol is available as 180 milligram oral tablets, and Nexlizet is available as 180 milligram pempedoic acid, 10 milligram ezetimibe oral tablets, and the recommended dose is 1 tablet once daily with or without food. And then in April 2024, Amgen announced that it will discontinue the manufacture of the Repatha Pushtronic system on June 30th of 2024. Other Repatha devices, including the SureClick auto-injector, will remain available, and Amgen stated that this decision was made to maintain its high standards for the patient experience. And that is all I have for lipotropics. I can take any questions.
Thank you, Nina. Any questions from the board for Nina? And I do see one stakeholder list. Oh, Marissa, do we want to review the PDL before we get the...
This is Marissa. Yep, let me go ahead and pull it up. I apologize, I don't have it completely pulled up.
You're orchestrating a lot of tabs. Sure.
So let me show you the classes. All right. So let me get rid of those bone density regulators, actually. All right, there we go. So these are the anti-hyperlipidemics drug classes that, oh, I'm not showing it.
Yeah.
Thank you. Let me, you'd think by 2024 I would know how to show my screen by now, but hopefully you can see that now. Is it good? Okay, good. So here I have the anti-hyperlipidemic drug classes that Nina was mentioning. So for the first one, I'll go through the adenosine triphosphate citrate lyase inhibitors. So we have the Nexletol and the Nexlizet. And in that class, we do have the Nexletol, which is just the bempedoic acid as the preferred product. For the angiopoietin-like protein inhibitors, we do have Evkeeza. That one is a carve-out, so it doesn't have a preferred status, but we do include it on the PDL just for communicating what is carved in and carved out. So that's why you won't see a status there, but we do cover it. For microsomal triglyceride transfer protein inhibitor, we just have Juxtapid, and that product we do have preferred. And for the PCSK9 inhibitors, our preferred products in that class are all of the Repatha formulations. So I know Nina had mentioned the Pushtronics is being discontinued, but it still shows up on our drug file. So until that actually gets discontinued and out of the system, then it'll just pretty much automatically disappear. But for now, it's still here. But we do have the Repatha SureClick and Repatha syringe. The other two products, Leqvio and Praluent, are non-preferred. And I can take any questions from the board about the PDL.
Marissa, Kavita here. If you scroll over all the way to the right, so yes, we see for example, the very top one, right? So bempedoic acid, it is preferred, but it has a prior auth requirement. So yes, exactly where you're at. There's no policy though. So how is the prior auth determined, or what is required for the prior auth?
Typically, if you don't see what so if there's no policy, it probably won't populate here. But in that case, since we do not have a clinical policy for it, it would just be reviewed for medical necessity per the labeling. So that's really what we would be looking for.
So is that to say, for example, with bempedoic acid, the labeling or FDA approval said that it's for individuals who either haven't achieved the LDL lowering as needed on statins or they're statin intolerant. So is that to say if the patient is statin intolerant, that would be covered? Like that would meet the criteria for prior auth?
That would be one of them, yeah. So we would make sure in those reviews that we are looking at, the LDL, if it is called out in the label, the statin use, whether they've used it, are they intolerant? And then also if there are any other kind of clinical reviews, clinical labs that might be of relevance for these particular drugs that we might want to look at. So any particular drug-drug interactions, things like that, we would also take those into consideration. But we don't have any like set criteria. You'd just be kind of looking for those hallmark kind of labs or markers that are called out in either the label or kind of important clinically, you would think.
Okay. Thank you. Other questions from the board? Okay. Hearing none, we can proceed with stakeholder input. Nanya, I see Josh Wakeman from Amgen on the list. Is Josh here?
Yes,
I'm here. Can you hear me?
Yes, we can. Give us one moment, Josh. I'm going to allow either Nanya or Marissa, I don't know who's controlling the timer, to get that on the screen.
This is Marissa. Yeah, I'm going to go ahead and pull up the timer and the questions. So let me get that all squared away.
And Nanya, we do have the COI form already completed, right? So
yes, Josh completed the COI form, so you can have the timer. Perfect. Thank you.
Thank you for doing it ahead of time, Josh. And the floor is yours.
All right. Well, thanks for having me. And it's always good to see Repatha as the preferred PCSK9 inhibitor on the Apple Health PDL, particularly in light of the 2022 ECDP update on behalf of the ACC-AHA that actually says that LDL-C threshold should be less than 55 now for very high-risk patients. So as a lipid specialist myself, it warms my heart to see all the available tools in the toolbox now for people to get them living in a safer neighborhood where there are fewer criminals, given that every LDL particle is potentially a criminal. And if you want to get living in a nice, safe, gated community, there's nothing more potent and cleaner than PCSK9 inhibition. And so I just wanted to give you guys just a little brief update on some of the new things that we've seen with Repatha, because one of the criticisms from the early Fourier trial is that even though it reduced heart attacks and strokes over a very short time, 2.2 years, it was just a very short trial. And so it was like, okay, we need to see what goes on with the long term here. And now we have open label extension data from almost 9 years now. And what do we see? We see less new onset diabetes over time, less myalgias, no signals for cognitive concerns, and no signal for hemorrhagic stroke. Really, there were no side effects that emerge other than the occasional injection site reaction, which is very, very reassuring when it comes to the safety of these things for our patients. Additionally, there was an exploratory analysis on cardiovascular mortality, and in fact, there was a 23% reduction in cardiovascular mortality for people who started Repatha sooner than people who were late to the party. And this really fits a nice framework because first we see within 4 hours of injection, we see LDL-C start to drop with Repatha. And then if we have LDL-C dropping, we'd expect to see benefit on plaque stability and even plaque regression. And we do see that. And then we would expect if plaque characteristics are improving, there would be a reduction in cardiovascular events. And we do see that. And then over time, we would expect to see a benefit in cardiovascular mortality. And now we have the data to support that. And so really exciting stuff. And like I always say, Repatha it's a clean and potent way to get living in a nice, safe, gated community if you've been broken into when it comes to cardiovascular disease. Given that it lowers LDL cholesterol 60% and lowers the risk of heart attack and stroke, particularly for these high-risk patients to get them under LDL cholesterol goals of 55. So thanks for your time. I really appreciate it and look forward to chatting again in the future when we have even more cool stuff to share.
Thank you, Josh. Any questions from the board for Josh? Okay. Any other stakeholders that were not registered, Nanya?
I do not see any hands raised.
Right on. Okay, so then we can proceed to the motion.
This is Marissa. I'm just pulling them up now. So let me go ahead and just share it over here.
Oh, I guess Kavita here. So when do we expect those policies to come out? Like,
this is Marissa. For the Nexletol product that you referenced earlier, I don't have an ETA on when that policy will be presented, at least to you all. So we are in the process right now of kind of prioritizing the policies that we do want to bring forth to you in 2025. So that schedule is pending. It was not, as far as priority wise, I will be very transparent. It didn't seem like it was a very high priority policy that needed to be created. So it may or may not show up next year. But we are trying to prioritize kind of the higher priority ones for 2025. So I guess kind of more to come on that.
Okay, thank you.
Mm-hmm.
This is Laura Bestie. I motion that all products in the drug classes listed on slide 2 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Peter Barkat, I second the motion.
All in favor, please say aye.
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 Any opposed or abstain? Great, then the motion carries. Thank you. And back to Nina for agents for substance use disorder.
All right, thank you. So next is substance use disorders. We're gonna go over agents for opioid withdrawal, opioid antagonists, opioid partial agonist subcutaneous, and opioid partial agonist transmucosal. So next we'll be going over opioid abuse and misuse. So prescription and illicit opioid abuse and misuse has reached national interest and was declared a national public health emergency by the Department of Health and Human Services acting secretary in 2017. The 2022 National Survey on Drug Use and Health reported that there was an estimated 46.6 million Americans aged 12 years and older who were current illicit drug users and approximately 8.5 million people aged 12 years or older in the United States who misused opioid in the last year. Approximately 48.7 million people aged 12 years and older in 2022 were considered to have substance use disorders in the past year. including 29.5 million people with an alcohol use disorder, 27.2 million people with a drug use disorder, and 6.1 million with an opioid use disorder, and I'll refer that as OUD. In 2020, the U.S. Preventive Service Task Force issued a final recommendation statement on screening for unhealthy drug use. For adults, the recommended screening implemented when service for accurate diagnosis, effective treatment, and appropriate care can be offered or referred. And for adolescents, current regimen is insufficient to determine the benefits and harm of screening for unhealthy drug use. Okay, next we have the 2022 CDC guidelines. So when opioids are prescribed, the CDC advised clinicians to evaluate for risk factors for opioid overdose in the patient and household members and offer naloxone. The recommendations emphasize the careful tapering of opioids to avoid withdrawal symptoms in current pain patients and individualize assessment of risks and benefits for continued high dose treatment. Regarding medications for opioid dependence, the CDC states prescribers should offer treatment for OUD, such as medication assisted treatment, such as buprenorphine or methadone. Buprenorphine, alone or in combination with naloxone and methadone treatment, have been associated with reduced overdose deaths and reduced all-cause mortality. Naltrexone is also an effective option, particularly for highly motivated individuals, but has not been evaluated in persons with concomitant pain. Adherence is a consideration with injectable naltrexone, as individual must be motivated to follow through with monthly long-acting injections. Because the effectiveness of oral naltrexone is limited by poor medication adherence, oral naltrexone should not be used except under very limited circumstances, such as patients who would be able to comply with observed daily dosing. Naltrexone also requires full withdrawal from opioids prior to initiation, which may present a challenge, and the CDC states there is no duration limit for the treatment of OUD with buprenorphine, methadone, or naltrexone. Okay. In January 2024, following FDA request, Emergent extended the shelf life of newly produced naloxone Narcan 4 mg nasal spray to 4 years, which was previously only 3 years shelf life. The extension is only applicable to products manufactured after January 17th of 2024. In August of 2024, a new generic was approved for Lucimira 0.18 milligram tablet, and it is anticipated to launch immediately. And that is it for substance use abuse. I'll pass it back to the committee.
Thank you, Nina. Kavita here. Questions from the board for Nina? God will wait for Marissa to load the Apple PDL.
All right, this is Marissa. So I am showing our substance use disorder drug classes. This isn't, I will caveat this, clearly it's not the whole, well, I think it is actually. I was thinking of the opioids in general, I'm sorry. So I withdraw what I said. I'll just go through these class by class. So for the first one, we have the agents for opioid withdrawal. In this class, we do have the Lucimira and the generic lofexidine. That one is non-preferred, and it looks like there's PA on that. For substance use disorder, opioid antagonists, for this one, it's easier for me to just say what is preferred. So we have the Cloxato, which is the naloxone spray, various naloxones. We have the spray, the syringe, the vial, all preferred without PA. We have naltrexones, auto-injectors, tablets. We have Opvi, which is nalmefene. And then we also have other kind of branded naloxones as well. And then we have Revive, Vivitrol, and Zimhi. Those are all preferred without PA. For the opioid partial agonist subcutaneous, we do have Brixadi and Sublocade. Those are, Brixadi is preferred without PA. And then Sublocade, we do have, it looks like it's preferred with the PA. We do have a policy for that. And then for opioid partial agonist transmucosal, these are these Suboxones. We do have brand Suboxone film preferred without PA, as well as it looks like the generic tablets preferred.
I just wanted to correct, I think so Brixadi and Sublocade are both without PA.
Oh, it is. Yes. I'm
It's
sorry.
the Subutex, the buprenorphine HCl tablet sublingual that does have a PA, and that is like a thing that is a big deal for us. And so I just want to make sure that's really clear.
Yes. Thank you for correcting that. It is for the buprenorphine tablets that we have the PA. And I can take any questions from the board about PDL.
Okay. And Nania, do we have any stakeholders? I don't see any listed.
And I don't see anyone's hands raised.
Okay, so then if no questions for Nina or for Marissa, we can look at the motion.
Is now the time that we would talk about removing the PA from Subutex, or would that be a different meeting? Because that's like a huge agenda item for like WSMA, WFP, like every group that I'm a part of. And if this is the meeting to do it, then I want to do it. But I'm not.
So this is Donna. Your Subutex meaning which one?
Buprenorphine HCl sublingual tablets.
The monotherapy. I think we're already in the process of doing that, Zoe.
Great.
It just hasn't been done yet.
Okay.
And that's for monotherapy, right?
Yes.
Yeah.
That's definitely the biggest barrier for like saving lives right now.
It's on our radar.
Okay, awesome. Is that relevant to this motion or is it not part of?
I don't think so.
Okay, sounds good. Because it's listed as preferred, so that wouldn't affect the wording of the motion, I think. Okay, I'm happy to do this motion if other people don't have any other objections. I think that the correct things are preferred on the list. Okay. So I move that all products in the drug classes listed on slide 4 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not medically appropriate, or only one product is preferred.
This is Greg
Michael
Hudson. I second.
Go ahead, Greg.
Yeah, sorry. This is Greg Hudson. I second.
Great. All in favor, please say aye.
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 Any opposed or abstain? Great, and the motion carries. Okay, next item is movement disorder agents. Is the board okay doing that before we take our break? Yeah, I see some nodding heads. Okay, let's do that one more, that topic, and then we can take our break.
Over to you, Nina.
you. Okay, movement disorders. Okay, on the next slide, we'll be going over Huntington's disease. So chorea, an abnormal involuntary twisting and or writhing movement, is a characteristic features of Huntington's disease, a rare and fatal genetic disorder resulting in neurodegeneration of the brain, which affects roughly 4.1 to 8.4 per 100,000 people in the US. Chorea affects approximately 90% of people with Huntington's disease and often develops early, gradually worsens, and plateaus in late stages. Chorea symptoms may be aggravated by stress and anxiety, and as the disease progresses, it can interfere with patients' function, and chorea is replaced by dystonia and Parkinsonism. No therapy currently exists to delay the onset of symptoms or prevent the progression of the disease. However, symptomatic treatment may improve the quality of life and prevent complications. So here we have the 2022 International Parkinson's and Movement Disorders Society use the grading of recommendation, assessment, development, and evaluation approach and appraised 22 randomized controlled trials involving 17 interventions targeting several predetermined questions. However, the high quality data were limited. The data found that both deutetrabenazine and tetrabenazine are likely efficacious for chorea. Deutetrabenazine is likely efficacious for motor impairment, while tetrabenazine is unlikely to be efficacious. Deutetrabenazine is likely efficacious for dystonia, but data was too limited for tetrabenazine. And deutetrabenazine and tetrabenazine were determined unlikely efficacious in functional capacity improvement or well as gait imbalance. Regarding safety of interventions, the group categorized deutetrabenazine as unlikely to be harmful in worsening depression, while tetrabenazine was considered likely to be harmful. Deutetrabenazine extended release Altesto XR was not approved at the time of this publication, and valbenazine, Ingrezza, and Ingrezza Sprinkle was not yet approved for this indication at the time of publication. Okay, on the next slide, we have Altesto XR deutetrabenazine. So in May 2023, FDA approved the higher strength ER tablets, 30, 36, 42, and 48 milligrams. And then in July 2024, FDA approved a new intermediate strength ER tab, 18 milligrams. And a new 4-week titration kit was also approved, which contains 7 ER tabs of each of the following strength: 12, 18, 24, and 30 milligrams. Okay, next we have Ingrezza valbenazine. In May 2024, FDA approved Ingrezza sprinkle capsules for patients who have dysphagia or difficult swallowing. The capsule contains 1 oral granule that can be sprinkled onto soft food, and the capsule content should not be mixed with milk or water and should not be administered via enteral tubes. The Ingrezza sprinkle will be available as 40, 60, and 80 milligram capsules. And that is all I have for movement disorders. I can take any questions.
Thank you, Nina. Kavita here. Questions from the board for Nina? Okay, and I do see we have 2 stakeholders listed. Is Omer Aziz? Oh, sorry, let's look at the formulary first and then we'll have the stakeholders. Thank you, Marissa.
This is Marissa, no worries. Excuse me, it's pretty straightforward. So this is our movement disorder class. We have the products that Nina mentioned. So we have Austedo, Ingrezza, tetrabenazine, and brand name Xenazine. In this class, our preferred products are Austedo all the different formulations, the tablets, the titration packs, the XR formulation, and the generic tetrabenazine. And Ingrezza is non-preferred. We do have a policy for that product. I think it's going live here in the next couple of months, if not next month, which you did all review, I think, sometime this year. So I can take any questions from the board.
Thanks, Marissa. Questions from the board?
This is Peter. Just wanted to clarify about I think there was a point about risk for depression with tetrabenazine versus deutetrabenazine. It looks like deutetrabenazine had the more favorable safety profile and is also preferred on here. I just wanted to confirm.
This is Marissa. Yes, we do have Austedo preferred without PA, which is the deutetrabenazine. Hopefully that was to me, Peter. I don't know if that was to me or Nina.
Yeah, thank you. Yeah, I was just trying to recall for the safety profile from earlier slides and make sure that matched up, but I thought it did, and thanks for confirming.
Yes, Marissa, no problem.
Okay, great, thank you. Any other questions for Marissa? And if not, we can start with Omar Aziz from Teva Pharmaceuticals. We have your COI form. Thank you for filling that out.
Hello, well, it's afternoon where I am, but it's probably morning where you are. So thank you so much. My name is Omar Aziz. I'm with the Field Value Evidence and Outcomes team, part of the medical affairs at Teva. I just want to provide some quick updates around Austedo or deutetrabenazine. As Prime so eloquently stated before, Austedo XR was approved and launched with strengths of 6, 12, and 24 milligrams. And this year, additional strengths of 18, 30, 36, 42, and 48 milligram strengths are approved. Now, what this means is that there are now 7 different one-pill, once-a-day dosing options for deutetrabenazine, which allows providers to give a dose that's flexible to find the optimal dose for the patient that controls the symptoms and minimize effects. I just want to let you know that Austedo BID formulation is still available on the market for patients who require this. Austedo does not have clinically important drug-drug interactions with CYP3A4 inhibitors or inducers. I also will note that the Austedo and Austedo XR have a box warning for patients with Huntington's disease for depression and suicidality, but that does not apply to the tardive dyskinesia indication and is consistent with the box warning across the class for VMAT inhibitors. I want to refer the committee to the full prescribing information for Austedo XR as well as Austedo. And in closing, I thank you so much for your time. I respectfully ask the committees for maintain access to Austedo and Austedo XR. I'm available for you if you have any questions. Thank you so much for your time.
Thank you, Omer. Any questions from the board? Okay, thank you. And then we have Anna Nepomuceno. I might be mispronouncing your last name. I apologize. Are you online?
Yes, can you hear me?
Yes, we can.
And if
Wonderful.
you can do a favor, please answer the question on the screen, please, Anna. Thank you.
Okay, so my name is Anna Nepomuceno. I'm speaking on behalf of NAMI Washington. And I am not a provider or a patient, and there is no conflict of interest.
Thank you.
Can I go ahead and start?
Yes.
Okay, great. Thank you. On behalf of NAMI Washington, I am asking for preferred status for all FDA-approved medications for the treatment of tardive dyskinesia or TD. There are currently 2 FDA-approved medications for treating TD, and only one has a preferred status, leaving people with TD no other options for treatment. It is critical that people with TD have treatment options based on their individual needs and that they are not restricted to a single compound. These medications have different drug interactions, metabolizer status statuses and side effect profiles. In light of these variances, we strongly support patients and their prescribers continuing to have both options available to them. Before diagnosis and treatment, having TD is a deeply challenging reality, especially considering that many people develop TD as a result of a long-term use of certain antipsychotics used to treat serious mental illness, which has its own effects on functionality. TD is estimated to affect over 600,000 people in the US. About 1 in 4 people who take antipsychotic medications for many years can develop TD. People experiencing symptoms are often confused about and unsure of what is happening to them. Many people with untreated TD will find themselves breathing harder, making uncontrollable clicking sounds with their tongue, and experiencing face twitching, voice wavering, and an inability to be physically still. They may be uncomfortable in social situations. They'll often have difficulty securing and sustaining employment. The impact of TD, if untreated, can devastate a person's ability to face the world and cause extreme social isolation. Thankfully, the availability of TD medications has given patients new hopes. TD treatment can change people's lives in ways that they and their loved ones never thought possible. This year, NAMI Washington received feedback from an individual experiencing the challenges associated with TD. Her symptoms compelled her to pull away from society, putting her livelihood at stake since she was also unable to continue her career as an attorney. Once the patient started receiving treatment, she reported very positive results to the point where she felt empowered to re-enter society. With treatment, this patient experienced a renewed confidence to live her life and continue on with her career. To people whose lives have been impacted by TD, access to treatment means acceptance, it means feeling comfortable in their own skin, it means achieving professional goals in the workforce. To put it differently, access to TD treatments means feeling human again. Washington is one of only 4 states that do not provide parity for TD medications, meaning that they are not preferred medications. There are no generics for treatment of TD, just these 2 approved medications. On behalf of NAMI Washington and our members across the state, I strongly encourage the board for parity and open access to both TD medications as preferred agents within the movement disorder class. Thank you very much for your time.
Thank you, Anna. Questions from the board for Anna? Okay. Any other stakeholders, Anya?
Yes, we have Anna Marie. Anna Maria, you can unmute yourself and answer the question on the screen, please. Thank you.
Right, Anne Marie, I am speaking on behalf of AAPPN. I am a provider. I see almost exclusively Medicaid clients. I do have a potential conflict of interest to report. I am a paid speaker for long-acting injectable for Teva Pharmaceuticals. Teva first has Austedo, but I'm not going to speak about Austedo specifically. All right, so I'm a psych NP. I serve community mental health clinics in Thurston, Mason, and Grays Harbor counties. I've had the privilege of treating patients with serious mental illnesses, including schizophrenia, schizoaffective disorder, and other psychotic disorders for the past 7 years. Many of these patients are covered by state health insurance and rely on antipsychotic medications as a cornerstone of their treatment. I'm testifying today to bring your attention to the critical healthcare challenges faced by my patients and to advocate for legislative changes that support the well-being of rural populations. In these communities, access to healthcare is severely limited. Many of my patients struggle with transportation, often unable to afford the gas or lacking reliable vehicles. Compounding this issue is limited availability of internet and cell phone access, which hinders telehealth options that could otherwise bridge the gap in care. The small rural hospitals in our area experience a high turnover of physicians, which exacerbates the lengthy wait times for patients to see primary care provider, ranging from 3 to 6 months or more. In this environment, I'm often the healthcare provider who sees my patients most frequently, routinely every 3 months at a minimum. My consistent presence allows me to develop a deep understanding of their health needs, providing continuity and personalized care that is otherwise lacking. Despite the critical role that ARNPs like myself play in these communities, there is a proposed requirement for physician oversight on a specific medication, Ingrezza. This is particularly problematic when there are no local psychiatrists and scarce neurologists, often requiring travel to Olympia or beyond. Requiring a physician who has had no prior contact with the patient to approve certain medications, such as VMAT2 inhibitors, is not only impractical, but also punitive. It places an unnecessary burden on patients who are already struggling to access care. I urge the committee to consider reforms that recognize the capabilities of ARNPs and allow us to practice to the full extent of our training and expertise. By removing unnecessary barriers to prescribing medications, we can ensure timely and effective treatment for our patients, reducing the strain on overburdened healthcare systems and improving healthcare outcomes in rural communities. Thank you for your attention to this pressing issue. I am committed to working collaboratively to find solutions that enhance healthcare access and quality for all residents of Washington State.
Thank you, Anne-Marie. Any questions for Anne-Marie from our board? Okay. Any other stakeholders, Nania?
Yes, we have John Dearson. John, if you can please go ahead and answer the question on the screen, and you can give your testimony. Thank you.
Yeah, absolutely. Thank you. As you mentioned, my name is John Deason, and I'm here representing Neurocrine Biosciences Medical Affairs Department. I am not a provider or a patient, and I am an employee, as I mentioned, of Neurocrine Biosciences. So good morning. Awesome. Thank you. So good morning. I appreciate the opportunity to join the board here today. Just had two quick items that I wanted to bring to the board's attention. As Nina had mentioned, there is a new FDA-approved formulation for Ingrezza. Ingrezza sprinkle capsules are a new oral granules formulation, and it received FDA approval on April 30th of this year for the treatment of tardive dyskinesia, or TD, and chorea associated with Huntington's disease in adults. It's important to note that many patients with TD and HD chorea experience dysphagia or difficulty swallowing. The Ingrezza sprinkle capsule is easy to open, and the contents or the granules can be easily sprinkled on soft foods such as applesauce, yogurt, or pudding for oral administration. In a survey of 250 patients with TD experiencing moderate to severe involuntary movements, 37% of patients reported that their movements impacted their ability to eat and drink. Most people living with chorea associated with Huntington's disease will also experience swallowing issues. The availability of a treatment for chorea that can be easily sprinkled onto food is very helpful in reducing the burden of taking a pill for these individuals as well as their caregivers, especially as the majority of these patients will experience dysphagia as their disease progresses. Ingrezza Sprinkle offers the same dosage strengths, 40, 60, and 80 milligrams, as well as the same once daily dosing as the Ingrezza capsule. I'd also like to appreciate the opportunity to respectfully request that the board consider moving Ingrezza to preferred on the state PDL to allow patients and providers in the state of Washington choice when considering FDA-approved options for the effective treatment of their TD or Huntington's disease-associated chorea. TD is often irreversible, and it requires unique management. It's important to keep in mind that when we're discussing the treatment of TD, the underlying condition that the majority of patients with TD are receiving antipsychotic treatment for is due to a serious mental illness. This could be schizophrenia, schizoaffective disorder, or a mood disorder. In these patients with both a serious mental illness as well as TD, they must not only deal with the stigma associated with a serious mental illness, but also the additional stigma associated with the, the involuntary movements, making access to FDA-approved VMAT2 inhibitors for the treatment of TD, including Ingrezza, important. In summary, Ingrezza is an effective treatment for adults with tardive dyskinesia and adults with HD-associated chorea, providing simplicity for both patients as well as providers, as it will always be one capsule, once daily, and this is regardless of a patient's maintenance dose. Ingrezza can be safely used in patients with no dosage adjustment required for mild, moderate, or severe renal impairment, and is the only FDA-approved VMAT2 inhibitor that can be used safely in patients with moderate or severe hepatic impairment at a reduced dose of 40 milligrams once daily. Again, appreciate the board's time and attention today, and would again respectfully request the committee consider adding Ingrezza to the state PDL. I'm happy to answer any questions you may have.
Thank you, John. Questions from the board for John? Okay. Other stakeholders, Nanya?
No, no one else's hands are raised.
Okay. We can have a look at the motion.
Could you go back to the PDL for a second, just because we heard so much about that?
And this is Greg Hudson. I think I have a question. Maybe this is for Marissa. I know the guidelines we reviewed today were for Huntington's and Parkinson movement disorders. I'm wondering if there's a separate guideline for tardive dyskinesia, or if this is sort of included in this overview.
This is Marissa. You might have been referencing maybe Nina's presentation.
Yes, excuse me.
Yeah, no worries. And looking at it, and Nina, feel free to chime in. It doesn't look like there's anything specific in your slides about the tardive dyskinesia. So I don't see anything specific about guidelines in that. But feel free to elaborate if I'm missing anything, Nina.
Okay, so yeah, I didn't mention anything of tardive dyskinesia, but it is part of the class overview. I'm checking real quick if there wasn't any guideline updates in the past year, but I want to look at the most current guidelines and I can pull that up. Yes, the most recent guideline was in 2020. APA updated the guidelines for the treatment of schizophrenia. They recommended routine assessment for TD in patients using antipsychotics. They recommended that patients who have moderate to severe or disabling TD related to antipsychotic therapy be treated with a reversible VMAT2 inhibitor, specifically tetrabenazine, or valbenazine. Patients with mild TD can also be considered for treatment with a VMAT2 inhibitor following an assessment of several factors, such as patient preference, impairment, and psychosocial functioning impact. They state that deuteratetrabenazine or valbenazine is preferred over tetrabenazine due to the data supporting their use, efficacy, safety, pharmacokinetic considerations. Other factors should also be considered when selecting which agent is most appropriate for a specific patient, such as hepatic impairment, renal impairment, metabolizer status, drug interactions. And then deutetrabenazine ER and valbenazine in grains of sprinkles were not approved at the time of the publication.
This is John McKay here. I had a question regarding our stakeholder referencing is there a policy that requires a behavioral health expert or psychiatrist to prescribe this class?
This is Marissa. I can speak to that. We don't have a policy that's alive right now. There was a policy that you all did review. The date is escaping me. Let me actually see when it will be going live. It's in the final stages. Let's see. And I will double check. Okay, so actually it actually should have just gone live October 1st. So technically this policy is supposed to be live right now. In our current policy, we do have criteria where it's prescribed by or in consultation with a neurologist or a psychiatrist. And that goes for both the Huntington's disease, chorea, and tardive dyskinesia. We do have that in our policy.
So this is Laura, just a quick question. So based on that policy, if a provider went to prescribe Ingreza over Austedo, would they have to fail tetrabenazine first before using valbenazine?
They would have to step through Austedo first.
Okay, but they wouldn't have to fail two agents, just the Austedo.
It's either or. If they've stepped through deutetrabenazine or tetrabenazine, I believe. Let me see the way it's written. I might have misspoke. Let me just
Hi, Marissa. I think they have to go through through deutetrabenazine.
Yes, it's just
So
deutetrabenazine.
if they've tried tetrabenazine, they will also have to try deutetrabenazine.
Is there any sort of like cost information about why?
Ingrezza is extremely more costly than
Okay.
Austedo, which is why we have it on PA. So
Okay.
if they are relatively equally effective, we want you to try
Yeah.
the least costly one first.
Yeah,
And
I
I
think the
just
cost
found,
differential is a little over $3,000 per month between the two.
okay. I just found a systematic review from 2024 that they're both like extremely similar in terms of effects and side effects. So I wasn't able to find anything in that to make it seem like one is better than the other.
This is John McKagan. I just wonder about with an established diagnosis of a movement disorder, if it would be, I don't know, preferable or allowed to have like primary care take over the prescribing. If like in conjunction, if maybe psychiatry made the initial diagnosis, if it's necessary to have that ongoing requirement just to improve access to care. I just I kind of hear what one of
I
our
think that would
stakeholders said.
I think that would be allowed for with this policy. I don't remember the exact language, but I thought it said something like in conjunction or consultation with a neurologist or psychiatrist.
Yeah, when I've done that for rheumatology, which is like a similar phenomenon, I just write the name of the person on the form, and I don't tend to have them see them again.
This is Greg Hudson. I think speaking to our stakeholders' concern about access to care. I mean, I believe there's been past criteria, excuse me, past criteria that's been adjusted to include psychiatric ARNPs to include this in their scope of practice. I don't see a reason why this couldn't be included as well.
Marissa, is the policy, I guess, addenda or adjustment something that we would do now? Is that up for discussion now?
This is Marissa. No, so we wouldn't be changing the policy because it is already live. I can take it back for a possible update. And I'm sorry, I must have missed what the amendment was to the policy, but I can take it back for future updates, but it wouldn't be something that would be reflected as soon as possible. It would be a little bit, I actually can't tell you how long it would take depending on the update, but I can take it back for consideration.
I don't think we're necessarily proposing any, or maybe we are proposing the change yet, but it's what's being brought up for discussion is in point number 2, prescribed by or in consultation with neurologist or psychiatrist ARNP or psychiatric ARNP. That's, I think, what's up for discussion right now to allow for access to care. So maybe that can be on the agenda at one of the future meetings.
Yeah, this is Greg Hudson. I'd recommend that be included as a recommendation for future items, just in terms of adequate scope of practice for psychiatric ARNPs.
This is Marissa. Yeah, I can definitely take that back for updating, not even just for the valbenazine policy, but probably across the board, just to take that into consideration for the different provider types that we do have.
Sounds fair. And I think, yeah, if in general, it seems like the rule of thumb would be if the state allows it, would we just follow state laws? But yes, that sounds like a great agenda item for one of our future meetings. I think that'd be very beneficial.
This is Marissa, and I will say, as a clinical reviewer myself for some of these requests that we get, if I did see and I think this is the expectation, if we did see a request come from a psychiatric ANRP, I would certainly count that. I wouldn't discount that as not meeting criteria. I definitely would take that, and if it's still approvable, I'll approve it, but still take that into consideration for sure.
That's helpful to know. Thank you, Marissa. Other questions from the board? I know one of you had asked to look at the formulary. Did you get your question answered about that? Maybe it was Zoe, I think.
Yep. Yeah.
Okay. All right. Yeah, any other questions for Marissa, for Nina, or for any of our stakeholders? And if not, then we'll look at the motion. Okay. Kavita Chawla, I move that all products in the movement disorders agents class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or one product is preferred.
Peter Barkat, I second the motion.
All in favor, please say aye.
Aye.
Aye. Aye.
Any opposed or abstain?
Actually, this is Laura. I just had one question.
Please.
So it says at least 2 preferred products, but aren't we saying they only have to try one product?
It depends on which preferred product they tried. So if they tried tetrabenazine, they still have to try deutetrabenazine. If they tried deutetrabenazine, then they can move on to Ingrezza. And I think the reason why that one's kind of carved out is because it's written that way in the prior auth policy for Ingrezza.
Okay, so since it's in the prior auth, it's okay for it to say at least 2, even though technically it wouldn't be.
Yeah, because we made an exception in the
prior
PA
auth
policy. Yep.
Yeah, this is Marissa. Whatever is in the policy would certainly override that.
Okay.
Because we would be very specific about what non-preferreds they would have to try.
Okay.
Yeah.
I'm in agreement then.
Good question.
Were you starting to say something, Greg?
No, I think I had my question answered. Thank you.
Okay. Okay, any opposed or abstain? Okay, and with that, the motion carries. Okay, I am doing a time check and looking at the schedule. So we're at 11:40. Our plan was to take a break right now. Does that still sound good to everybody? The next chunk of topics, which is the oncology agents, is a 2.5-hour potentially topic. So we'll probably break in the midst of that to take a lunch break as well. Does that sound reasonable? Yeah? Okay. All right. So 10-minute lunch break, Nanya, please. Oh, not lunch, just break.
No problem.
Hey, Nanya, I'll put the sign up on my computer, so don't worry about it.
Okay, thank you.
Welcome back, board. Just making sure we have quorum. Okay, great. All right, Nina. So before I have you get started, I think we had planned on splitting up the oncology agents portion, maybe. So Marissa, correct me if I'm wrong. So maybe do about like an hour, 15 minutes-ish before lunch, and then the remaining after?
This is Marissa. Yep. Unless the DOR board wants to do something different. But that sounds like a good plan to me.
Okay, so approximately go until 1 o'clock.
Yeah, that works for me if it works for everyone else. I don't want to speak for the rest of the board.
Yeah, okay, I see nodding. All right, sounds good. Thank you, Nina. Take it away.
Okay. Next, we're going to go over oncology injectables, antibodies injectable.
Sorry, this is Marissa. Hey, Nina. You can just go straight from section to section, so you don't have to stop if you don't need.
Okay, sounds
Yeah.
good. Thank you. Okay, on the next slide, we'll be going over multiple disease states first, and then we'll go into the drug updates after. So the first one we have is lung cancer. So lung cancer is the leading cause of cancer death in both men and women in the United States. Current 5-year survival is estimated to be 23%, an increase from 15% reported in 2019. Decline in lung cancer mortality in the U.S. have been accelerating in recent years, and there has been a steady decline in the incidence of lung cancer diagnosed in the U.S. The number of diagnoses declined 2.3% in the most recent measurement. Despite these encouraging trends, there are still more U.S. lung cancer deaths annually than deaths from breast cancer, prostate cancer, and colorectal cancer combined. The primary risk factor for the development of lung cancer is smoking tobacco, accounting for approximately 85% to 90% of all cases of lung cancer. While chemo prevention agents are not yet established, lung cancer screening using low-dose computerized tomography, LDCT, is recommended by the U.S. Prevention Service Task Force, who expanded their lung screening cancer guidelines in 2021. The guidelines now recommend annual screening with LDCT for patients 50 to 80 years of age who are current smokers with at least 20 pack year smoking history and former smokers who have quit within the past 15 years. On the next slide, lung cancer is divided in two major classes, non-small cell cancer, lung cancer, and small cell lung cancer, SCLC. These two types of lung cancer differ in their biology, treatment, and overall prognosis. NSCLC accounts for more than 80% of all lung cancer cases. There are two major types of histology subtype of NSCLC, squamous cell and non-squamous cell. Non-squamous cell includes adenocarcinoma, which is the most common type of lung cancer diagnosed in the U.S. and is also the most common subtype occurring in non-smokers. Depending on the stage of the disease at diagnosis and the histology subtype, the treatment of lung cancer may involve surgery, radiation, chemotherapy, targeted therapy, immunotherapy, or a combination of these approaches. Next disease state is cholangiocarcinoma, also known as biliary tract cancers, which I will refer to as BTC. The tumors originate in the epithelium of the bile duct and are typically classified as either intrahepatic or extrahepatic, depending on their location within the biliary tree. BTC is rare in the United States, with approximately 8,000 people diagnosed each year. This may be an underestimate because these cancers can be difficult to diagnose and may often be classified as other types of cancers, such as hepatocellular carcinoma or cancer of unknown origin. The average age of diagnosis is between 70 and 72 years of age. Treatment includes a surgical consultation to assess if the patient is a candidate for resection or possible organ transplantation. And for a patient with unresectable or metastatic disease, there is an increasing role for molecular profiling. Intrahepatic cholangiocarcinoma harbors IDH1 mutations in 10% to 20% of cases, and mutation in FGFR2 fusions occur in about 9 to 15% of cases. These mutations provide an opportunity for targeted therapies. Okay, next we have gastric cancer. The incidence of gastric cancer has been declining steadily since the 1930s, yet it remains a major cause of cancer death in the United States and globally. The high mortality rate reflects the prevalence of advanced disease at presentation. In population-based series of Western populations, the 5-year survival rate for patients with completely resected stage 1 gastric cancer is approximately 70 to 75%, and it drops to 35% or less for stage 2B disease and beyond. Efforts to improve treatment results beyond those obtained with surgery alone have included adjuvant and neoadjuvant strategies. The positive impact of such therapies on survival in patients with resected gastric cancer have become clearer over time, although there is no consensus as to the best approach. Next, we have bladder cancer. So in 2023, an estimated 82,290 new cases of bladder cancers will be diagnosed in the United States, and an estimated 16,710 deaths will occur in 2023 due to these malignancies. It is the fourth most common cancer in U.S. men, but it is less common in women. The average age of diagnosis is 73 years, and as a result, patients commonly have coexisting medical conditions. Urothelial carcinoma, also known as transitional cell carcinoma, is the most common type of bladder cancer. Other much rarer bladder cancers include squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and sarcoma. Risk factors for bladder cancer include smoking, which is responsible for about half of all bladder cancers, male gender, white race, personal family history of bladder cancer, radiation of the pelvic region, environmental exposure such as occupational or drug-related, and chronic urinary tract infections. Okay, moving along, we have cervical cancer. So almost all cervical cancer cases are linked to infection with high-risk human papillomavirus, HPV, an extremely common virus transmitted through sexual contact. Although most infection with HPV resolve spontaneously and cause no symptoms, persistent infection can cause cervical cancer in women. Cervical cancer is the fourth most common cancer in women globally, and in 2022, an estimated 660,000 women were diagnosed with cervical cancer worldwide, and about 350,000 women died from the disease. Effective primary and secondary prevention approaches will prevent most cervical cancers, such as HPV vaccination and screening for and treating precancerous lesions. When diagnosed, cervical cancer is one of the most successfully treated forms of cancer, as long as it is detected early and managed effectively. Cancers diagnosed in late stages can also be controlled with appropriate treatment and palliative care. And with a comprehensive approach to prevent, screen, and treat, cervical cancer can be eliminated as a public health problem within a generation. Next, we have uterine cancer. So over 90% of uterine cancer are endometrial, originating in the epithelium. The major risk factor for endometrial carcinoma, which I'll refer to as EC, is the presence of a clinical scenario associated with an excess of endogenous or exogenous estrogen without adequate opposition by a progestin. EC develops in approximately 3% of females in the United States and is the fourth most common cancer among females in the United States after cancer of breast, lung, and colon. The incident peaks between ages 60 and 70 years, but 2 to 5% of cases occur before age 40. Most patients are diagnosed when disease is still confined to the uterus and thus have a greater than 90% 5-year survival rate. EC typically present with abnormal uterine bleeding, and other presentations include abnormal cervical cytology findings on cervical cancer screening, abnormal finding on imaging, or discovered incidentally when hysterectomy is performed for benign disease. Next, we have melanoma skin cancer. So the incidence of melanoma skin cancer in the US is increasing, but the death rate due to melanoma is declining. Melanoma is increasing more rapidly than any other malignancy except for lung cancer in women. Conversely, there have been recent declines in mortality for melanoma. The median age of diagnosis is 65 years old, and risk factors for the development of melanoma include both genetic factors, such as skin type, inherited germline mutations, and environmental factors such as excess sun exposure and UV-based artificial tanning. Despite the relationship to UV exposure, melanoma can also occur in areas of the body without substantial sun exposure and can occur in any ethnic groups. There are also non-cutaneous forms of melanoma arising from melanocytes present in mucosal membranes or the uveal tract of the eye, and the treatment of non-cutaneous melanoma may differ from that of cutaneous melanoma, and treatment should be individualized in those patients. Okay, next we have nasopharyngeal carcinoma, which I will refer to as NPC. NPC is the predominant tumor type arising in the naropharynx. Although NPC is rare in most part of the world, it is endemic in southern China, Southeast Asia, North Africa, and the Arctic, where undifferentiated non-keratinizing squamous cell carcinoma is the predominant histology. The major etiologic factors for endemic NPC are genetic susceptibility, early age exposure to chemical carcinogens, and Epstein-Barr virus infection. Analysis of Epstein-Barr virus DNA in plasma is useful for screening at-risk populations for NPC. It can detect the cancer at an early stage with a superior treatment outcome compared with those that are unscreened. Okay, next we have acute lymphoblastic leukemia, which I will refer to as ALL. So ALL is the most common form of childhood leukemia, with 53.5% of patients diagnosed before the age of 20 years old. Approximately 29.6% of cases of ALL are diagnosed at age 45 years or older, with 13.7% of cases diagnosed at 65 years or older. Overall survival outcomes for children with ALL have improved dramatically in the last decades, such that 5-year overall survival is estimated to be 89% in children. Unfortunately, as age of diagnosis increase, the overall survival rate decreases. So adolescents and young adults have an estimated of 61% overall survival, while adults diagnosed with ALL have only a 20 to 40% overall survival rate. Aside from the patient's age, prognosis is also influenced by cytogenetic markers or genetic abnormalities, and newly diagnosed pediatrics ALL patients are often classified for the purpose of treatment as being low risk, standard risk, high risk, or very high risk. All treatment regimens for ALL are generally divided in 2 phases. These phases often include an induction phase, consolidation phase, and a maintenance phase. Okay, moving on to esophageal cancer. So So squamous cell carcinoma and adenocarcinoma accounts for over 95% of esophageal malignant tumors. In the 1960s, squamous cell carcinoma accounted for more than 90% of esophageal tumors in the United States, and adenocarcinomas were considered uncommon. However, adenocarcinoma now accounts for more than 60% of all esophageal cancers in the US. Patients with advanced thoracic or cervical esophageal carcinoma usually present with progressive dysphagia and weight loss. The diagnosis of esophageal and esophagogastric junction cancer is usually established by endoscopic biopsy. Early cancers may appear as superficial plaques, nodules, or ulcerations. Advanced lesions may appear as strictures, ulcerated masses, circumferential masses, or large ulcerations. The endoscopic appearance of a large mucosal mass is frequently diagnostic of esophageal cancer. Biopsies confirm the diagnosis in more than 90% of cases. The prognosis of esophageal cancer is strongly associated with the disease stage. Accurate clinical staging of both local tumor extent and the presence of or absence of distant metastasis is critical for estimating prognosis and selecting the appropriate treatment strategy. Okay. Now we have ovarian cancer, which includes fallopian tube or primary peritoneal cancer. The risk of ovarian cancer increases with age, with the median age at diagnosis is 63 years. The 5-year survival rate is 50.8%, and more than half of the patients present with advanced disease. Ovarian cancer has been shown to have a higher prevalence in families with BRCA1 or BRCA2 genotypes, and in these patients, the onset of disease is usually at a younger age. However, patients with these mutations accounts for only 15% of all ovarian cancers. Primary treatment for advanced ovarian cancer usually begins with cytoreduction surgery to remove as much gross disease as possible because patients with more complete debulking have better outcomes. Majority of patients, excluding those with very early stage disease, are recommended to receive postoperative adjuvant systemic chemotherapy. Recommended protocols generally includes a taxane and a platinum agent. Okay, moving along, we have follicular lymphoma. This is the most common subtype of indolent non-Hodgkin's lymphoma and accounts for approximately 22% of all newly diagnosed cases of non-Hodgkin's lymphoma. While the clinical course of follicular lymphoma is usually indolent, with about 90% of diagnosed patients surviving to 5-year post-diagnosis and about 50% of patients surviving to 20-year post-diagnosis, about 3% of patients progress to a more aggressive lymphoma, such as diffuse large B-cell lymphoma. Okay, next is multiple myeloma, which I will refer to as MM. So MM is a malignant neoplasm of plasma cells that accumulate in the bone marrow, leading to bone destruction and marrow failure. MM accounts for approximately 1.8% of all malignancies and 18% of all hematologic malignancies in the US. The median age of diagnosis is 69 years old, and the 5-year relative survival rate is 57.9%. The overall survival rate now is estimated to be 8 to 10 years among patients with standard risk disease, but it is significantly lower in patients that exhibit high-risk features. Patients with symptomatic MM must have at least one myeloma-defying event, which may include hypercalcemia, renal insufficiency, anemia, or lytic bone lesions. This constellation of effects is often referred to by the acronym CRAV and is likely an indicator of in-organ dysfunction associated with MM. MM is sensitive to a variety of agents, but the disease is not considered curable with current available drug therapies. The clinical course of MM usually involves initial response to chemotherapy, but these responses may be transient, thus retreatment with multiple rounds of therapy with different agents may be required to treat relapse. Okay, next we have on the next slide is hepatocellular carcinoma, which I will refer to as HCC. The incidence of liver cancer stabilized in the past few years, particularly in men. However, the stabilization followed decades of increases. Rates for younger adults, less than 50 years, decreased from 2015 to 2019 by 2.6% per year for liver cancer. In March 2024, American Society of Clinical Oncology updated its guideline on the use of systemic therapy for advanced HCC. The recommended first-line treatment in patients with Child-Pugh Class A advanced HCC who have an ECOG performance score of 0 to 1 are atezolizumab plus bevacizumab or durvalumab plus tremelimumab. Alternatives are sorafenib, lenvatinib, or durvalumab. Second-line treatment is based on first-line treatment use and include tyrosine kinase inhibitor nivolumab, ipilimumab, as well as durvalumab plus tremelimumab or atezolizumab plus bevacizumab if not used as first line. For third-line treatment, any of the previous mentioned agents may be used if they do not have an identical mechanism of action as a previously used agent. Okay, next we have alveolar soft part sarcoma, which I will refer to as ASPS. So ASPS is a rare, slow-growing soft tissue tumor of an unclear cause. It is among the least common sarcoma, representing 0.2 to 1% of large studies of soft tissue sarcomas. ASPS is characterized by a painless mass that most commonly arises in the leg or buttocks, with a particular affinity to travel to the lungs as multiple nodules, presumably while the sarcoma itself is still small. This disorder is very rare because it involves a specific breaking and joining event between two chromosomes called an unbalanced translocation. This finding is observed in essentially all patients with ASPS examined so far and cannot be passed on to children. There are no families in which multiple family members have this disorder. ASPS tends to occur more often in younger individuals, specifically adolescents and young adults, and treatment is with surgery for the primary place where the sarcoma arises. Radiation therapy is sometimes considered as an adjunct to surgery depending on the tumor characteristics. For a disease that travels to the lung, sometimes surgery is possible to remove nodules, but often systemic therapy is the only option for treatment. Okay, we finally made it through the disease states, and now we're going over the drug updates. So first we have Keytruda pembrolizumab, which has multiple updates in the past year. So the first one is in October 2023, FDA approved a new indication for treatment of patient with resectable tumors greater or equal to 4 centimeter or not node positive, NSCLC in combination with platinum-containing chemotherapy as neoadjuvant treatment, and then combined as a single agent as adjuvant therapy after surgery. In November 2023, Keytruda had 3 updates on indication. So it was approved for use in combination with gemcitabine and cisplatin for locally advanced unresectable or metastatic biliary tract cancer. And it revised the indication of pembrolizumab with trastuzumab, fluoropyrimidine, and platinum-containing chemotherapy first-line treatment of patients with locally advanced unresectable or metastatic HER-positive gastric or gastroesophageal junction adenocarcinoma to restrict use in patients whose tumor express programmed death ligand 1 as determined by an FDA-approved test. It was also approved for use in combination with fluoropyrimidine and platinum-containing chemotherapy for the first-line treatment of adults with locally advanced unresectable or metastatic HER2-negative gastric or GEJ adenocarcinoma. In December of 2023, FDA expanded the advanced metastatic urothelial cancer indication to include the following: Keytruda in combination with enfortumab vedotin EJFV for treatment of adults with locally advanced or metastatic urothelial cancer. They removed the limitation of ineligibility for cisplatin-containing chemotherapy. They also granted this indication full approval from accelerated approval. In January of 2024, FDA approved a new indication for use in combination with chemoradiotherapy for treatment of patients with fecal 2014 stage 3 to 4A cervical cancer. And then in June 2024, FDA approved a new indication for use in combination with carboplatin and paclitaxel, followed by Keytruda as a single agent for the treatment of adults with primary advanced or recurrent endometrial carcinoma. On the next 4 slides, I've listed out the full list of FDA indication for Keytruda. So again, it covers melanoma, non-small cell lung cancer, malignant pleural mesothelioma, head and neck squamous cell cancer, classical Hodgkin's lymphoma, primary mediastinal large B-cell lymphoma, urethral cancer, microsatellite instability high or mismatch repair deficient cancer, microsatellite instability high or mismatch repair deficient colorectal cancer, Merkel cell carcinoma, hepatocellular carcinoma, gastric cancer, esophageal cancer, cervical cancer, renal cell carcinoma, endometrial carcinoma, tumor mutational burden high cancer, triple negative breast cancer, advanced classical Hodgkin's lymphoma in adult primary medicinal large B-cell lymphoma, biliary tract cancer, and cutaneous squamous cell carcinoma. Okay, the recommended dosing is stratified by indication and age and is administered as an intravenous infusion over 30 minutes after dilution. Here I've listed the recommended doses for the new and revised indication, which happen to all be 200 milligram every 3 weeks or 400 milligram every 6 weeks. Okay, our next drug is Opdivo nivolumab. So in October 2023, FDA approved an expanded indication for melanoma 2B and stage 2C. Updated indication is for adjuvant treatment of patients greater or equal to 12 years old with completely resected indication for melanoma stages 2B, 2C, 3, or 4 melanoma. In March of 2024, a new indication was approved for in combination with cisplatin and gemcitabine for first-line treatment of adults with unresected or metastatic urothelial carcinoma. On the slide, the next two slides, I've listed the full indication. So there's melanoma, non-small cell lung cancer, malignant pleural mesothelioma, renal cell carcinoma, squamous cell carcinoma of the head and neck, classic Hodgkin's lymphoma, and urethral carcinoma. We also have colorectal cancer, hepatocellular carcinoma, esophageal cancer, and gastric cancer. Okay, the recommended dose for Opdivo is stratified by indication, age, and weight, and is administered by IV infusion after dilution based upon recommended infusion rate for each indication. Here, I listed the dosing for the updated indications. So for adjuvant therapy of melanoma in pediatric patients less than 40 kilogram, the recommended dose is 3 milligram per kilogram every 2 weeks or 6 milligram per kilogram every 4 weeks. For adults and pediatric at least 40 kilograms, the recommended dose is 240 milligram every 2 weeks or 480 milligram every 4 weeks. For adjuvant treatment of urothelial carcinoma, the recommended dose is 240 milligram every 2 weeks or 480 milligram every 4 weeks. Okay, on the next slide, we have Lactorzi. So in October 2023, FDA approved Lactorzi, toripalimab TPZI, a PD-1 blocking antibody, as the first FDA-approved medication for the following indications. So it was approved for in combination with cisplatin and gemcitabine for first-line treatment of adults with metastatic or recurrent locally advanced nasopharyngeal carcinoma, and as a single agent for treatment of adults with recurrent unresectable or metastatic NPC with disease progression on or after platinum-containing chemotherapy. Warning includes immune-mediated adverse reactions, infusion-related reactions, complications of allogenic hematopoietic stem cell transplantation, and embryo-fetal toxicity. The recommended dose for in combination with cisplatin and gemcitabine is 240 milligram IV every 3 weeks, and the recommended dose as a single agent is 3 milligram per kilogram IV every 2 weeks. The first infusion can be infused over 60 minutes, and if there are no infusion-related reactions during the first infusion, then the subsequent infusions can be administered over 30 minutes. Lactorzi is available as 240 milligram per 6 ml solution in a single dose vial. Okay, next we have passive enfortumab vedotin EJFB. So in December 2023, FDA approved expanded indication for use in combination with pembrolizumab for the treatment of adults with locally advanced or metastatic urethral cancer. For the expanded indication, the recommended dose is 1.25 milligram per kilogram, up to a maximum dose of 125 milligram, given as an IV infusion over 30 minutes on day 1 and 8 of a 21-day cycle until disease progression or unacceptable toxicity. Okay, next we have Besponsa, inotuzumab, ozogamicin. So in March 2024, FDA approved for an expanded indication for treatment of relapse or refractory CD22 positive B-cell precursor ALL in adults and pediatrics at least 1 year old. Previously, this was only approved for adults with this indication. The recommended dose is based on patient's body surface area, and the first cycle for all patients is 1.8 8 milligram per meter square per cycle, administered as 3 divided dose on day 1, day 8, and day 15. Cycle 1 is 3 weeks in duration, but may be extended to 4 weeks if the patient achieves a complete remission or complete remission with incomplete hematologic recovery, and or to allow recovery from toxicity. Okay, on the next slide, we have Rybrevant amivantamab VMJW. In March 2024, FDA approved indication for combination with carboplatin and Pemetrexed for first-line treatment of adults with locally advanced or metastatic NSCLC with EGFR exon 20 insertion mutation as detected by a FDA-approved test. FDA has also granted traditional full approval as a single agent for treatment of adults with locally advanced or metastatic NSCLC with EGFR exon 20 insertion mutations as detected by an FDA-approved test whose disease has progressed or after platinum-based chemotherapy. In August of 2024, a new indication was approved for in combination with lazertinib for first-line treatment of adults with locally advanced or metastatic NSCLC with EGFR exon 19 deletions or exon 21 L858R substitution mutation as detected by an FDA-approved test. On the next slide, the recommended dose is based on baseline body weight and is administered as an IV infusion after dilution. It is for the use in combination with carboplatin and pemetrexate. The recommended dose is administered every 3 weeks, and the order of administration is Pemetrexed first, carboplatin second, and then Rybrevant last. For use in combination with lazertinib, it's administered weekly from weeks 1 to 5, then every 2 weeks starting week 7 and onwards. No doses should be given during week 6. Treatment should be administered until disease progression or unacceptable toxicity. And when given on the same day, Rybrevant should be administered after lazertinib. And for this indication, it is recommended to administer anticoagulant prophylaxis during the first 4 months of treatment to prevent venous thrombotic events. Okay, in March of 2024, FDA approved Tevimbra, tislelizumab, JSGR, a PD-1 blocking antibody as monotherapy for treatment of adults with unresected or metastatic esophageal squamous cell carcinoma after prior systemic chemotherapy and did not include a PD-L1 inhibitor. Warnings are similar to the previous drugs, so immune-mediated adverse reactions, infusion-related reactions, complication of allogenic hematopoietic stem cell transplantation, and embryo-fetal toxicity. The recommended dose is 200 milligram as an IV infusion once every 3 weeks until disease progression or unacceptable toxicity. And it should be the first infusion can be administered over 60 minutes, and if tolerated, subsequent infusions may be administered over 30 minutes. Tevimbra will be available as 100 milligram per 10 ml solution in a single dose vial. Okay, next we have Elahere, mirvetuximab, soravtansine, GYNX. So in March of 2024, FDA converted the accelerated approval to full approval for adult patients with folate receptor alpha positive, platinum resistant epithelial ovarian, fallopian tube, or primary peritoneal cancer who have received 1 to 3 prior systemic treatment regimens. On the next slide, we have Enhertu from trastuzumab deruxtecan. So in April of 2024, FDA granted an accelerated approval for treatment of adults with unresected or metastatic HER2 positive, immunohistology chemistry IHC3 positive, solid tumors who have received prior systemic treatment and have no satisfactory alternative treatment options. Okay, and for the new indication, the recommended dose is 5.4 milligram per kilogram, given as an IV infusion once every 3 weeks until disease progression or unacceptable toxicity. And next we have Tivdak, which is tisotumab vedotin TFTV. So in May of 2024, FDA granted traditional approval for recurrent or metastatic cervical cancer with disease progression on or after chemotherapy in adult patients. Tivdak was previously approved for accelerated approval for this indication. Okay, moving along, we have Imdelltra tarlatamab, DLLE. So FDA granted an accelerated approval for treatment of adults with extensive stage small cell lung cancer with disease progression on or after platinum-based chemotherapy. Imdelltra carries a black box warning for cytokine release syndromes, including serious or life-threatening reactions, and neurologic toxicity, including immune effector cell-associated neurotoxicity syndromes, ICANS, and require patient monitoring for approximately 24 hours during and after the first 2 doses, and patients should remain within 1 hour of the healthcare settings for a total of 48 hours. The observation period can decrease for subsequent doses. Other warnings include cytopenia, hepatotoxicity, and embryo-fetal toxicity. Imdelltra is administered through IV infusion over 1 hour with step-up doses given on cycle 1. Day 1 is 1 milligram, day 8 is 10 milligram, and day 15 is 10 milligram, followed by administration of 10 milligram every 2 weeks until disease progression or unacceptable toxicity. And it will be available as 1 milligram or 10 milligram of lyophilized powder in a single dose vial for reconstitution and further dilution. Okay, next we have Blincyto. So in June 2024, FDA approved a new indication for Blincyto, blinatumomab, for treatment of CD19 positive Philadelphia chromosome negative B cell precursor ALL in the consolidation phase of multi-phase chemotherapy in adults and pediatric patients at least 1 month of age. For the new indication, Blincyto should be administered as a single cycle of 28 days of continuous infusion, followed by a 14-day treatment-free interval, a total of 42 days. For patients weighing greater or equal to 45 kilograms, the recommended dose is 28 micrograms per day. And for patients less than 45 kilograms, the recommended dose is 15 microgram per meter square per day, not to exceed the 28 micrograms per day. Okay, next we have Imfinzi, durvalumab. So in June 2024, FDA approved a new indication for use in combination with carboplatin and paclitaxel, followed by Imfinzi as a single agent for treatment of adults with primary advanced or recurrent endometrial cancer that is a mismatch repair deficient And then in August 2024, FDA approved another indication for use with a platinum-containing chemotherapy as neoadjuvant treatment, followed by single-agent influenza as adjuvant treatment after surgery for adults with resectable tumors greater or equal to 4 centimeter or node positive, NSCLC, and no known EGFR mutations or anaplastic lymphoma kinase rearrangement. On the next slide, we can see the recommended dose is indicated by the indication, patient weight, and schedule. So dMMR endometrial cancer, patients greater or equal to 30 kilogram. The recommended dose is 1,120 milligram in combination with carboplatin and paclitaxel every 3 weeks for 6 cycles, followed by 1,500 milligram every 4 weeks as a single agent. Patients less than 30 kilogram for the dMMR endometrial cancer, the recommended dose is 15 milligram per kilogram every 3 weeks in combination with carboplatin and paclitaxel for 6 weeks. And then you would follow as a single agent 20 milligram per kilogram every 4 weeks. For resectable NSCLC, patients greater or equal to 30 kilogram, the recommended dose is 1,500 milligrams. And patients less than 30 kilogram, the recommended dose is 20 mg per kg. And it should be administered every 3 weeks if it's neoadjuvant treatment. And if it's for adjuvant treatment, then it will be every 4 weeks. Okay, next we have Enkimli, epcoritamab BYSP. And in June 2024, FDA granted accelerated approval for the treatment of adults with relapse or refractory follicular lymphoma after at least 2 lines of systemic therapy. The recommended dose for follicular lymphoma requires step-up dosing over the course of 10 cycles. Each cycle length is 28 days to a 48 milligram dose given on day 1 of each cycle by the 10th cycle. Okay, in August 2024, a new indication for Darzalex Faspro, which is combination of daratumab and hyaluronidase FIHJ, was approved in combination with bortezomib, lenalidomide, and dexamethasone for induction and consolidation in patients with newly diagnosed multiple myeloma who are eligible for autologous stem cell transplant. There is a limitation. It's not indicated and is not recommended for the treatment of patients with light chain amyloidosis who have New York HA class 3B or class 4 cardiac disease or Mayo stage 3B outside of controlled clinical trials. Okay, it is the recommended dose is 1,800 milligram of daratumumab and 3,000 units of hyaluronidase administered sub-Q into the abdomen over approximately 3 to 5 minutes according to recommended schedule. Next, we have Jemperli, dostarlimab, GXLY. So FDA has approved this in combination with carboplatin and paclitaxel, followed by Jemperli as a single agent for all patients with primary advanced or recurrent endometrial cancer. Jemperli was previously only approved for this indication in patients with mismatch repair deficiency or microsatellite instability high tumors. recommended dose for this indication is 500 milligram IV every 3 weeks for 6 cycles in combination with carboplatin and paclitaxel, and then 1,000 milligram IV every 6 weeks as monotherapy until disease progression or unacceptable toxicity, or up to 3 years. Okay, last we have Tecentriq Hybreza, atezolizumab with hyaluronidase, TQJS, and this was approved as the first and only PD-L1 inhibitor for subcutaneous injection in the United States. It has been approved for all the adult indications of IV atezolizumab Tecentriq, including treatment of certain patients with NSCLC, SCLC, HCC, melanoma, and ASPS, which I listed out under FDA indications. Okay, warning includes immune-mediated adverse reactions, infusion-related reactions, complication of allogenic HSCT, and embryo-fetal toxicity. It is available as 1,875 milligram atezolizumab and 30,000 units hyaluronidase per 15 ml solution in a single dose vial. And the recommended dose and administration is different than the IV Tecentriq atezolizumab product. So the recommended dose for Tecentriq Hybreza is 1 15 ml injection administered subcutaneously into the thigh over approximately 7 minutes every 3 weeks by a healthcare professional. Okay, that's it for the antibodies IV. So we're going to go over to our oral oncology agents now. So this one is oncology agents gamma secretase inhibitors. Okay, so first we'll go over desmoid tumors. So for every 1 million people worldwide, 2 to 4 are diagnosed with a desmoid tumor per year. In 5% to 10% of cases, desmoid tumors may run in families and is also known as aggressive fibromatosis or desmoid type fibromatosis. It is most common in people between the age of 15 and 60 years old and are more common in females than males. Desmoid tumors grow from the connective tissue in the body and can occur anywhere in the body. And while the cells of the desmoid tumor do not travel to other parts of the body like cancer can, they can invade nearby tissue and are often very painful. Desmoid tumor can be hard to predict. They can shrink and go away on their own, or they can remain the same size, or they can grow very quickly. Treatment options include watch and wait for the cases where the tumor grows very slowly or even shrinks without any treatment. Surgery has been the standard treatment for desmoid tumors in the past, but this is changing given that the tumor often returns to the same location after surgery. So doctors are looking for other treatment options. Radiation therapy is also an option for some desmoid tumors, however, it may cause other cancers in the future. And the chemotherapy, there is no standard chemotherapy for desmoid tumors, but promising new drugs have been shown to shrink these tumors. Okay, on the next slide, we have Ogsiveo nirogacestat. So in November 2023, FDA approved for adults with progressing desmoid tumor who require systemic treatment. Warnings include severe diarrhea, so it's recommended to monitor and dose and modify for grade 3 to 4 diarrhea. Ovarian toxicity may occur, so it's recommended that female with reproductive function and fertility may be impaired, and to advise females of reproductive potential of the potential risk prior to treatment and monitor routinely. Hepatotoxicity, so elevated AST and ALT can occur. So it's recommended to monitor AST and ALT regularly and modified dose as recommended. It can also cause non-melanoma skin cancer. So it's recommended to perform dermatologic examination prior to initiation and routinely during treatment. Electrolyte abnormalities may occur. It's recommended to monitor phosphate and potassium regularly and modified dose as recommended. And then it also can cause embryo fetal toxicity. Recommended dose is 150 milligram twice daily until disease progression or unacceptable toxicity, and it is available as 50 milligram oral tablets. Next, we're going over oncology agent HIF2 alpha inhibitors. So we're going to go over renal cell carcinoma, which I will refer to as RCC. So cancer of the kidney and renal pelvis account for approximately 4% of all newly diagnosed cancers in the United States, with a 5% incident in male and a 3% incident in females. The median age of diagnosis is 65 years, and greater than 75% of cases are diagnosed in patients ages 55 years or older. The overall 5-year survival for patients diagnosed with RCC was 77.6% from the period of 2013 to 2019. If the disease is localized at time of diagnosis, outcomes are excellent with a 5-year survival of approximately 93%. However, patients diagnosed with advanced metastatic disease account for approximately 15% of diagnoses have much poorer outcomes with approximately a 17.4% survival rate at 5 years. Approximately 85% of kidney tumors are RCC, and approximately 70% of all RC have a clear cell histology. Other less common histologies are usually grouped together as non-clear cell tumors. The incidence of RCC in men is more than twice of that in women in the United States, and the most common presenting triad of symptoms include hematuria, flank mass, and flank pain. However, as the use of routine imaging have become more widespread, the frequency of incidental detection of RCC has increased, and only about 30% of patients are now diagnosed on the basis of symptoms. Okay. Here we have the 2023 NCCN guidelines. So for first-line systemic therapy of favorable risk, clear cell histology, relapse or stage 4 RCC, they recommend a tyrosine kinase inhibitor plus an immune checkpoint inhibitor as a category 1 preferred option. So specifically, azitinib plus pembrolizumab or cabozantinib plus nivolumab or lenvatinib plus pembrolizumab are the 3 TKI CPI regimens included. Other recommended regimens for the same group of patients include monotherapy with sunitinib or pazopanib, or the combination of axitinib plus avelumab or ipilimumab plus nivolumab. Azitumab monotherapy is an NCCN Category 2B recommendation, and it's listed as useful in certain circumstances. For the same group of patients with poor or immediate risk rather than favorable risk, ipilimumab plus nivolumab and the 3 TKI CPI regimens are listed as Category 1, preferred along with single agent cabozantinib being a Category 2A preferred options. Other options largely mirror the favorable risk option defined above. For subsequent therapy of RCC with clear cell histology, no preferred options are provided. Then other recommended regimen options are based on whether the patient is immuno-oncology therapy naive or has received prior IO therapy, which are all category 2A. And here I've listed the list of options for IO therapy for these patients. For patients with non-clear cell histology, single agent cabozantinib, sunitinib, axitinib, pazopanib, and everolimus is all category 2A recommendations, though cabozantinib and sunitinib are the preferred regimens. Okay. Here we have Welireg, pelzutifan, which had a FDA expanded indication in December 2023. FDA approved for patient with advanced RCC PD-1 or PD-L1 inhibitor with a vascular endothelial growth factor tyrosine kinase inhibitor. And then the recommended dose for the expanded indication is 120 milligram administered orally once daily with or without food. Okay, next we have oncology agent KRAS inhibitors. So we will be going over the disease state colon cancer. In the US, colon cancer is the third most diagnosed cancer, as well as the second leading cause of death from cancer in both men and women. In 2023, an estimated 106,970 cases of colon cancer will be diagnosed, and an estimated 52,550 deaths will occur in the US. Colon cancer typically affects older adults, though it can happen at any age. Treatments include surgery, radiation therapy, and medicines such as chemotherapy, targeted therapy, and immunotherapy. Okay, so we have Krazati, adagrasib, which has a new indication in June 2024. So FDA approved accelerated approval for use in combination with cetuximab for treatment of adults with KRAS G12C mutated locally advanced or metastatic colorectal cancer, as determined by a FDA-approved test who have received prior treatment with fluoropyrimidine, oxaliplatin, and irinotecan based chemotherapy. The recommended dose is 600 milligram orally twice daily. Okay, and this is our last oncology class, oncology agents, ornithine decarboxylase inhibitors. So we will be going over neuroblastoma, and this is cancer that starts in very early forms of nerve cells, most often found in an embryo or fetus. This is the most common cancer in infants, mainly younger than 1 year old. There are about 700 to 800 new cases of neuroblastoma each year in the United States, and some neuroblastomas grow and spread quickly while others grow very slowly. Sometimes in very young children, the cancer cells die for no reason and the tumor just goes away on its own. And then in other cases, the cells sometimes mature on their own and then grow into normal ganglion cells and stop dividing. Treatment depends on the risk group of the cancer, the child's age, and other factors, and might include more than one type of treatment. So treatment options include surgery, chemotherapy and related drugs, radiation therapy, high-dose chemotherapy, and stem cell transplant, retinoid therapy, and immunotherapy. Okay, and we have awilfrin, eflornithine. So in December 2023, FDA approved to reduce the risk of relapse of high-risk neuroblastoma in adults and pediatric patients with at least a partial response to prior multi-agent, multimodality therapy, including anti-GD2 immunotherapy. Warnings include hearing loss, myelosuppression, and hepatotoxicity, and baseline audiogram, CBC, and liver function tests should be performed prior to starting therapy. Ibuprofen may also cause embryo-fetal toxicity as well. The recommended dose is based on surface area and should be taken orally twice daily with or without food until disease progression, unacceptable toxicity, or a maximum of 2 years. And it is available as oral tablets, 192 milligrams. And that concludes our oncology section. I'm happy to take any questions.
Kavita, your amazing marathon run there, Nina. With especially difficult to pronounce medication names too.
Yes.
All right. Questions for Nina as Marissa's pulling up our PDO? Okay. All right. Go ahead, Marissa.
This is Marissa. Great job, Nina, marathoning through that. Definitely kudos to you. We are actually, I think, right on schedule, so that's perfect. So I'll be going through the oncology agents that Nina just kind of went through in very deep detail, but I'll just do the overview of the AHPDL. For the oncology agents, antibodies, injectable drug class, you will see that for the preferred status, a lot of them have X. And to be completely honest with you, we do have to re-examine this class. Some of these products on here, we do include on the PDL, some of them we don't. So there are some discrepancies, but for the sake of our DUR board meeting today, I will just consider us reviewing this class as a whole. These are, typically medically administered or professionally administered drugs. That's why you don't see that they have a preferred status, because we would only allow these through the medical benefit. You wouldn't typically see these through point of sale. So we do cover them on the medical side. Most likely, I would assume that a lot of these probably do have PA on them, just as like a general rule of thumb. So can't really speak too much on that, but that's really all that's going on that class. We don't have any that are preferred over the other at this time. But just wanted to caveat that we are still taking a look at this class, and we will determine whether or not we do truly want to include it on the PDL or not, because a lot of the IV drugs or medically administered drugs, we typically don't include them on the PDL unless there's some carve out or some type of circumstance where we would see it. But that's just kind of what's going on right now. For the gamma secretase inhibitors, we have Ogsiveo. And actually, just with all of the other oncology agents, we pretty much have them all preferred with PA. We don't have any clinical policies for them, so they would be reviewed for medical necessity per the labeling, but that's generally what's going on. Nothing too exciting in this class as far as utilization management, but we do cover them on our AHPDL.
Marissa, Kavita here. I see Peter has a question.
Yeah, thanks, Peter. Do any of these medications have site of care associated with them in addition to medical necessity review? Or is that the way that the contracts are written, does that not take into account any differential cost for site of care?
This is Marissa. I don't believe we do take that into account. Yeah, I don't believe we do look at that. Unless there is maybe some circumstance where we would have to look at that, like inpatient versus outpatient, or
Right.
y'all like
Yeah.
to think, yeah, in that regard, then yes, we would definitely take that into consideration. But if it's like a regular kind of covered outpatient drug, then not really.
Right. The reason I bring it up is I think more often Cytocare has been implicated as a utilization management strategy than actually medical necessity criteria. And a lot of these medications for other health plans that have been moved into kind of Cytocare restrictions um, to when appropriate, have people treated in, say, like an outpatient physician office as opposed to an outpatient hospital setting. And that gets really tricky. And so anyway, I know that Medicare doesn't, the way that the Medicare contracts work, actually, there's just no such, they don't recognize site of care. And so I was curious how that worked for Apple Health.
Yeah, I will say, as far as medical drugs go, when we do review them, like when they come out, we do take into consideration, like, do we want to allow it through an outpatient hospital or a professional setting? So that might be like maybe one of them. I guess it is, like you were saying, a utilization management, but that's really the extent. And then also considering if it is inpatient only, that's really the extent to really like what we consider for those. I guess that's really all I could really speak to. It does get kind of tricky sometimes. There are some drugs, that are coming out nowadays where I think they're considered covered outpatient drugs, but they're administered inpatient, and just everything for that has been kind of tricky for those types of drugs that have been coming out. So it's kind of uncharted territory or new territory that we're kind of having to maneuver around when those do happen.
Thank you for that, Marissa. Other questions for Marissa or for Nina? Okay. And then Nanya, do we have any stakeholders? Sorry, I'm pulling up.
We did not have any pre-registered stakeholders, and I do not see anyone's hands up.
Okay. So I guess with that, we could look at the motions.
And this is Marissa. I'm actually going to add the antibodies because that was not on here initially. 1, 2, 3, 4, 5. Yep. All right. And that should be good to go.
I think there's a typo under antibodies.
This is.
Laura's got a really good eye.
I thank you for catching. That did come up actually, and I'm surprised I caught that very quickly. But thank you.
This is Michael Corsillas. I'll read the motion. I move that all products in the drug class listed on slide 7 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products. Indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Vesti. I second the motion.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Okay, great. With that, the motion carries. And after that marathon, Nina deserves a break for lunch. Nanya, does that sound okay?
Sounds good.
Okay, see you all back in 30 minutes. Thank you.
Thank you.
We can hand it back. 1, 2, 3. Yes. All right. I see most of our board is back. So Nina, whenever you are ready to resume.
Okay, thank you. Next, we have endocrine and metabolic agents, NH3 inhibitors.
Hey, this is Marissa. Nina, for the next two, for the NH3 and I think the parathyroid, you can just go straight to parathyroid after, since we'll be doing a motion for both of them. One motion for both.
Okay, perfect. Right, so first we're going to go over hyperphosphatemia. Hyperphosphatemia is a risk factor for cardiovascular disease. Study has shown an increased risk of mortality in patients with CKD stage 5 receiving dialysis with hyperphosphatemia. Long-term hyperphosphatemia, along with elevated calcium times phosphorus product values greater or equal to 55 milligrams square per deciliter square, is linked to an increased risk of vascular, valvular, and other soft tissue calcification in patients with CKD. Soft tissue calcification occurring in vascular and cardiac tissue can lead to increased morbidity and mortality, and patients with elevated calcium phosphorus product values are at a significantly higher risk of death. The calcium phosphorus product is calculated by using the patient's corrected serum calcium level and serum phosphorus level. Okay, on the next slide is the 2017 KDIGO guideline. Since it's well over a year, I just included it here for completeness sakes. So on the next slide, we have Exfosa tenapanor, which is a new drug that was FDA approved in October 2023 to reduce serum phosphorus in adults with CKD on dialysis as an add-on therapy in patients who have an inadequate response to phosphate binders or who are intolerant of any dose of phosphate binder therapy. It is contraindicated in pediatric patients under 6 years of age and patients with known or suspected mechanical gastrointestinal obstruction. It can also cause severe diarrhea. The recommended dose is 30 milligrams orally twice daily before the morning and evening meals. It's recommended to monitor serum phosphorus and adjust the dose as needed to manage gastrointestinal tolerability. And it's not recommended to take right before a hemodialysis session. And it's recommended to take right before the next meal following dialysis. It is available as 10, 20, and 30 milligram oral tablets. Okay, next we have endocrine and metabolic agents, parathyroid hormones. And to point out on the previous slide, the medication that we're going over is under the prime therapeutic market basket, hyperparathyroidism, but the agent we're covering is actually indicated for hypothyroidism. So hypoparathyroidism is a rare disease most often caused by damage to the parathyroid glands from surgery or autoimmune disease. Patients with hypoparathyroidism has a low level of parathyroid hormone, which leads to hypocalcemia. Patients with hypoparathyroidism are typically treated with active vitamin D and calcium to raise blood calcium into the low normal range and can require large doses of calcium taken more than once a day. Symptoms of hypoparathyroidism vary depends on blood calcium levels and can include tingling or numbness in the fingertips, toes, and lips, muscle cramps and spasms, and seizures. So we have here Yorvipath, paloperidotide, which is FDA approved in August 2024 for the treatment of hypoparathyroidism in adults. For limitation, it was not studied for acute post-surgical hypoparathyroidism, and the titration scheme was only evaluated in adults who first achieve an albumin-corrected serum calcium of at least 7.8 milligram per deciliter using calcium and active vitamin D treatment. Warnings include unintended changes in serum calcium level related to number of daily injections. So make sure to use only one daily Yorvipath injection. Using 2 injections to achieve the recommended once daily dosage increases the variability of the total delivered dose. It can also cause serious hypercalcemia and hypocalcemia, so it is recommended to periodically measure serum calcium and monitor for signs and symptoms, and can cause a potential risk of osteosarcoma as well. The dosing is individualized based on serum calcium and may be administered by patient or caregiver after proper training. Recommended starting dose is 18 micrograms subcutaneously once daily and is titrated in 3 microgram increments or decrements with the goal of maintaining serum calcium within the normal range without the need of active vitamin D or therapeutic calcium doses. The maximum dose is 30 micrograms once daily, and if adequate response is not achieved with the 30 microgram dose, consider adding or restarting calcium and or vitamin D therapy and or seek other treatment options. It is available as 168 microgram per 0.5 mLs, 294 microgram per 0.98 mLs, or 420 micrograms per 1.4 mLs in a single patient use pre-filled pen. And that concludes the endocrine and metabolic agents. I'll answer any questions.
Sorry, go ahead with the medications, or do we have any stakeholders?
This is Marissa. Sorry about that, Kavita. Okay, I'll go through the endocrine and metabolic agents, NH3 inhibitors, and parathyroid hormones. The 2 drugs of note are really just the drugs, 2 drug products that Nina just went over. So Exposa and Yorvipath. And as you can see on our PDL, we do have them both preferred with PA. Don't have a policy for them, so just follow our usual medical necessity reviews. And I can answer any questions about the PDL.
There we go. I did see 2, see here. We have 2 stakeholders listed. Paul Miner, are you here?
Yep. So, Paul, if you can answer
Yes,
the
hello.
question on the screen.
Hello. Can you hear me?
Yes, I can hear you. If you can
Oh,
answer the
great.
question on the screen, please.
Um, I thought I did. I don't see a question on the screen.
Uh-oh.
Oh, name, are you speaking on behalf of a company and organization? Yes, I am. I'm an employee of Ascendis Pharma.
Okay.
And if you can, yeah, the
Great. But
remainder of the questions on there.
other questions? Are you a provider? No, I'm not. I'm not a patient. I do not have any conflicts of interest to report other than I am an employee of Ascendis Pharma, which is the manufacturer of Yorvipath. My name is Paul Miner.
Thank you.
Sorry about that.
That's okay. Okay.
Great. Well, thank you and good afternoon, everyone. My name is Paul Miner. I am a pharmacist and national director with medical affairs for Ascendis Pharma, and I realized that you already thoroughly reviewed the parathyroid hormone analogs and was uncertain as to how this review would go with the endocrine metabolic agents. So I know that you have introduced the product and that you have it available for patients in a preferred positioning. So rather than reiterate many of the things that were already addressed, I would make myself available to any questions. I did want to just take the opportunity to share with you that This is the first and only product available, and that while approved in August of this year, August 9th, is not yet commercially available, anticipated sometime in December or early part of 2025. The point I wanted to raise is that there is no other therapy available. There was a product Takeda had, Natpara, which was being made available for some patients through a special use program, which will be sunsetting this year. So I just wanted to make that available information. If I'm sure you knew it, but that you may have been getting some requests when it's commercially available prior to a review. But since you're reviewing it and you've made it preferred and available, I will defer the remainder of my time back to committee, and thank you for the consideration, but I will make myself available for any questions that you may have.
Thank you, Paul. Any questions from the board for Paul? Okay, great. Next, I see Michelle Reyes. Are you online?
Okay, Michelle?
Can you hear me?
Yes,
Yes,
we
we
can
can.
hear you.
Okay, there we are. Hi.
Hi, please go ahead and answer the
For
questions
those
on.
questions, yes, my name is Michelle Reyes. I am speaking on behalf of the Hypoparathyroidism Association. I am not a provider. I am a patient, and I don't have any conflicts of interest to report.
Thank you.
Hi, my name is Michelle Reyes, and I'm a two-time cancer survivor and a rare disease patient. The rare disease I have is called hypoparathyroidism, and it is why I am here today. Although I have had this disease for 30 years, we have not had an approved drug for treatment until August of this year. This drug is now trying to come to market, and I'm here to tell you why we so desperately need it to be approved to be covered. My journey began after my thyroid cancer diagnosis and the inadvertent removal of all of my parathyroid glands during surgery for my cancer. I was told I would just need to take one calcium pill a day and I would lead a normal life, no big deal. Well, that couldn't have been further from the truth. I experienced debilitating muscle cramps, my jaw locking up, my throat tightening to the point I couldn't breathe correctly, constant pins and needles, and at times the inability to do everyday tasks like carry my groceries, pick up my child. Heck, there were days where my child basically had to pick me up as I was unable to walk unassisted out of her school assemblies. I was hospitalized over 240 times in a 4 to 5 year period due to this disease. I also want to talk today about the way this disease is currently treated. The current standard of care is to take over-the-counter calcium and active vitamin D, sometimes also magnesium and potassium in large quantities. For me, this turned into 64 pills a day every 3 hours around the clock, never getting a full night's sleep for years. But I didn't have a choice. If I missed one single dose, I risked ending up in the ER. I also want to mention that taking this much calcium does further damage to your body by causing kidney disease and calcifications in other areas of your body, including your heart and brain. 3.5 years ago, I was lucky enough to begin a trial that changed my life. Now I take 2 pills a day, and one of them has absolutely nothing to do with this disease. My kidney disease has been completely reversed, and my quality of life is now amazing. I don't have to think about my disease on a daily basis, and I don't have to depend on others to function. I want to stress that I'm not the worst case scenario. I'm somewhere in the middle. What I can tell you is, without a doubt, that far too long we've treated this as a calcium disorder when it is first and foremost a PTH disorder. And until we treated my PTH, I never had relief. After 30 years with this disease, I finally feel like I have quality of life. The thought that I may lose this drug because it's too costly is terrifying. The thought that others may never realize what it's like to live because this drug won't be approved is heartbreaking. I thank you for your time today and for your consideration.
Thank you, Michelle, for sharing your story. Questions from the committee for Michelle? Okay. Thank you, Michelle. Nanya, any other stakeholders?
No, no other hands are raised.
Okay, board, are we ready to look at the motion or any other discussion?
This is Laura Bestie. I make a motion that I move that all products in this drug class listed on slide 9 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathered at discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Peter Barkat, I'll second that motion.
Thank you. All in favor, please say aye.
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 Any opposed or abstain? Okay, with that, the motion carries. And back over to Nina for hematopoietic agents.
Okay, next is hematopoietic agents, XCCR4 receptor antagonists. So next we'll be going over WHIM syndrome, which is a rare genetic disease that causes the body's immune system to not function properly. It reduces the numbers of mature neutrophils and lymphocytes circulating within the body, and it is estimated to occur in about 1 in 5 million live births, with approximately 60 cases have been reported in the medical literature. While symptoms vary, patients with WHIM syndrome can have recurrent infections, including pneumonia, sinusitis, skin infections, and are at high risk for life-threatening bacterial and viral infections. So here we have Xolremdy, mavorixafor, which is a new drug. So FDA approved it as the first drug for patients greater or equal to 12 years old with warts, hypogammaglobulinemia, infections, and myelokathesis, also known as WHIM syndrome, to increase the number of circulating mature neutrophils and lymphocytes. The drug is contraindicated with drugs that are highly dependent on CYP2D6 for clearance. It can cause embryo-fetal toxicity and can cause QTc interval prolongation. The recommended dose for patients less or equal to 50 kilogram is 300 milligram once daily. For patients over 50 kilogram, the recommended dose is 400 milligram orally once daily, and it should be administered on an empty stomach after an overnight fast and at least 30 minutes before food. And it will be available as a 100 milligram oral capsule. And that is all that I have for stem cell mobilizers. I'll take any questions.
Thank you, Nina. Questions for Nina from the board? Okay. Looks like a quick formulary review, Marissa.
Yeah, this is Marissa. So this is the CXCR4 receptor antagonist drug class. We just have one product, which is Xolremdy, and it is preferred, and there is PA on that product. I can answer any questions about the PDL.
Unmute. Any questions for Marissa? Otherwise, Nanya, if there are any stakeholders.
Trying to mute my Trying to mute myself and share my camera. No, I do not see any hands up. No.
Okay. All right, then we can look at the motion. Okay, it's Kavita Chawla. I move that all products in the hematopoietic agent CXC4 receptor antagonist class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or, as in this case, only 1 product is preferred.
This is John McKay, a second.
All in favor, please say aye.
Aye.
Aye. Aye.
Any opposed? Okay. With that, the motion carries. And back to Nina to review pulmonary hypertension agents.
Thank you. So next is pulmonary hypertension agents, active and signaling inhibitors. So next we'll go through pulmonary arterial hypertension, which I will refer to as PAH. So it is a progressive disorder characterized by increased pressure in the pulmonary artery, which carries oxygen-poor blood from the right side of the heart to the lungs. This is defined by the American Heart Association as a resting mean pulmonary arterial pressure of greater than 20 millimol Hg. Approximately 500 to 1,000 new cases of PAH are diagnosed in the United States each year. The prevalence of PAH is estimated to range from 15 to 50 per million in the US and Europe. However, pulmonary hypertension is heterogeneous and underdiagnosed. Although the number of approved therapies for PAH has grown in the past year, the prognosis is still poor, with a 3-year mortality rate estimated at 21%. Symptoms include dyspnea, lightheadedness, syncope, fatigue, peripheral edema, chest pain, palpitations, and visible or enlarged veins on the side of the neck, which may be exacerbated by exertion. Management of PH should be limited to specialized centers where clinicians are experienced in the evaluation and treatment of patients with PH. Okay, there are many causes of PAH, including idiopathic or underlying disease and hereditary causes, cellular changes in the walls of the pulmonary arteries, and it appears that mutations in the bone morphogenic protein receptor type 2 gene plays a key role in the pathogenesis of heritable PAH. Other etiologies in PAH include drugs and toxins, collagen vascular resistant, HIV, portal hypertension, chronic thromboembolism, and congenital heart disease. The World Health Organization, WHO, classifies PH patients into 5 categories based on the etiology. The group 1 refers to PAH, and the other 4 groups describes PH. So here we have Renravir, sotatercept, CSRK, which is a new drug. So in March 2024, FDA approved for the treatment of adults with PAH, WHO Group 1, to increase exercise capacity, improve WHO functional class, and reduce the risk of clinical worsening events. Warnings include erythrocytosis, and if severe, may increase the risk of thromboembolic events and hyperviscosity syndrome. It's recommended to monitor hemoglobin before each dose for the first 5 doses or longer if values are unstable, and then periodically thereafter to determine if dose adjustments are required. It can also cause severe thrombocytopenia, which increases the risk of bleeding. So it's recommended to monitor platelets before each dose for the first 5 doses, or longer if values are unstable, and periodically thereafter to determine if dose adjustment are required. Again, it can cause serious bleedings and then may cause embryo-fetal toxicity and impaired fertility. The recommended starting dose is 0.3 milligram per kilogram subcutaneously to a targeted dose of 0.7 milligram per kilogram subcutaneously every 3 weeks. This may be administered by the patient or a caregiver with proper training. And it is available as a 45 milligram or 60 milligram lyophilized cake or powder in a single dose vial. Okay, and then here we have pulmonary arterial hypertension agents, oral and inhaled. So these are the combinations. Okay, and this is Opsynvi, macitentan with tadalafil. So in March 2024, FDA approved Opsynvi, a combination of macitentan and tadalafil for chronic treatment of PAH WHO Group 1 in adults in WHO functional class 2 and 3. Macitentan reduces the risk of clinical worsening events and hospitalization, and tadalafil improves exercise ability. There is a black box warning for embryo-fetal toxicity. For all female patients, this is available only through the REMS program. And then it's contraindicated in pregnancy, hypersensitivity, concomitant organic nitrates, concomitant guanylate cyclase stimulators. And then it may cause fluid retention and hepatotoxicity. The recommended dose is 1 tablet taken once daily with or without food. And it is available as a film-coated tablet with macitentan 10 milligram and tadalafil 20 milligram or 10 per 40 milligrams. And that concludes the PAH agents.
Thank you, Nina. Okay, now allow Marissa to pull up the PDL.
This is Marissa. So I will be going through our pulmonary hypertension agents, the activin signaling inhibitors, and the combinations. So it's pretty straightforward for these two classes. We just have Winrevair and Opsynvi, which, as you can see on our PDL, we do have them non-preferred with PA, and we do have a policy that corresponds to the pulmonary hypertension agents. I don't have the other pulmonary hypertension agents included in this publication, which is like the tadalafil, sildenafils. There's other ones that are slipping my mind, but I do know that we do have those types like the PDE4 inhibitors preferred. So it's the expectation that they would step through those preferred products before they would be eligible for these newer products on the market. So I can answer any questions that you might have about the PDL. And I apologize, I don't have the other PAH drug classes displayed.
Thank you, Marissa. Questions from the board for Marissa? If not, I see some stakeholders listed, starting with Andy Kim. Are you online?
Yes, can you hear me?
Yes, we can.
Great, thank you so much.
If you can answer the questions on the screen, please, and then we'll start your time.
Yes, my name is Andy Kim, and I will be speaking on behalf of United Therapeutics Corporation. And then for the other question, I am not a provider nor a patient, and I do not have any conflicts of interest to report. Okay, good afternoon. My name is Andy Kim. I'm a medical science liaison with United Therapeutics Corporation. In May 2022, FDA approved Tyvaso DPI for the treatment of patients with pulmonary arterial hypertension, PAH, and pulmonary hypertension due to interstitial lung disease, PH-ILD, to improve exercise ability. Tyvaso DPI is a new formulation and inhalation device for Tyvaso and is the only dry powder inhaler approved by the FDA for use in PAH and PH-ILD. Tyvaso DPI was evaluated in the BREEZE study, and the primary objective was to evaluate the safety and tolerability of Tyvaso DPI during a 3-week treatment phase in 51 PAH patients on a stable regimen of Tyvaso inhalation solution who were transitioned to Tyvaso DPI. Patients who transitioned from Tyvaso to DPI demonstrated safety and tolerance. 96% of patients completed the 3-week treatment phase, while 2 subjects discontinued due to treatment-related adverse events. Adverse events were consistent with studies of inhaled treprostinil in patients with PAH, and there were no study drug-related serious AEs. Significant improvements in secondary study objectives were also observed at week 3, including 6-minute walk distance of 11.5 meters compared to baseline, overall patient satisfaction with the Tyvaso DPI inhaler as measured using the preference questionnaire for inhaled treprostinil devices, and PAH-SYMPACT patient-reported outcome questionnaire were observed in physical impacts and cognitive and emotional impacts. The 49 patients who completed the treatment phase of BREEZE opted to continue in an optional extension phase. Improvements in 6-minute walk distance compared to baseline were sustained in the optional extension phase through the data cutoff date up to 51 weeks. Given these findings, we ask that you maintain Tyvaso and Tyvaso DPI as preferred on the Washington State Medicaid PDL for PAH and PH-ILD patients that depend on your services for their medications. I thank you for your attention, and I'm happy to answer any questions.
Thank you, Andy. Any questions from the board for Andy? Okay. Let me see. Next we have Nirmal Guman. Are you online? Do you see them, Nanya? Yes? Okay. Can you unmute yourself, Nirmal?
Sorry, talking while muted. It looks like they must have logged out or maybe have technical difficulties.
Okay, maybe we can come back to them. Other
Nanya, this is Marissa. It does look like in the Q&A, Amy Hale said she would be speaking for Nirmal.
Oh, okay.
Okay, thank
I just
you.
saw that pop up. No worries.
Amy, are you online?
Hello, so sorry about that. We had to have a last minute change.
Good job tag teaming. If you can go ahead, please, and answer the questions on the screen.
Yes, my name is Amy Hale. I'm a principal scientific account lead with Johnson & Johnson Innovative Medicine. I'm neither a provider nor a patient. I have no additional conflicts of interest to report. Okay. Thank you for the opportunity to speak to you today about Opsemvi, a combination of macitentan and tadalafil. ADUATE, a phase 3 study, evaluated the efficacy and safety of Opsemvi compared to macitentan 10 milligrams and tadalafil 40 milligram monotherapies in patients with PAH, including treatment-naive patients and patients previously on ERA or PDE5 inhibitor monotherapy at baseline. The primary endpoint was a change in PVR from baseline to week 16. In the patients who were randomized to Opsemvi versus macitentan monotherapy, Opsemvi was associated with a 29% reduction in PVR. In the patients who were randomized to Opsemvi versus tadalafil monotherapy, Opsemvi was associated with a 28% reduction in PVR. In treatment-naive patients, Opsemvi was associated with a 30% and 34% reduction in PVR compared to macitentan and tadalafil monotherapies respectively. And in patients receiving prior ERA therapy, Opsemvi was associated with a 32% reduction in PVR compared to macitentan monotherapy. In patients receiving prior PDE5 inhibitor therapy, Opsemvi was associated with a 19% reduction in PVR compared to tadalafil monotherapy. The most common adverse events observed with Opsemvi were edema and fluid retention, anemia, and headache or migraine. Qualitative one-on-one semi-structured web-assisted interviews were conducted with the ADUATE trial participants and site investigators about their experience with the single tablet combination therapy, adherence, convenience, and the impact of a reduction in pill count. All participants preferred the open-label single-tablet combination therapy to the 4 tablets in the double-blind phase. Patients stated the single-tablet combination therapy was convenient, aided adherence, and had a positive impact on their day-to-day lives. Patients also expressed how taking more tablets made them feel more sick compared with single-tablet combination therapy. Additionally, patients acknowledged that single-tablet combination therapy improved their psychological well-being and reduced the stress of managing multiple tablets. Clinicians cited that the high pill burden in PAH causes their patients emotional distress, whereas patients had higher treatment satisfaction with the single tablet combination therapy. Clinicians from the interview predict the single tablet combination therapy will be well received in clinical practice and endorse prescribing single tablet combination therapy for treatment naive patients. For these reasons, please consider adding Opsumvy to the Washington Medicaid preferred drug list. Please refer to the full prescribing information for complete information. I want to sincerely thank you for your time and consideration today, and I'm here for any questions you may have.
Thank you, Amy. Any questions from the board for Amy?
Thank you.
Okay, thanks. And then any other stakeholders?
No other hands are raised.
Okay, great. So then we can go ahead and look at the motion, please.
Peter Barquette, I can make the motion. Move that all products in the drug classes listed on slide 12 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
Zoe Taylor, second.
All in favor, please say aye.
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 Any opposed or abstain? Okay, with that, the motion carries. Okay, and then back to Nina for the final big chunk, I think. Or are we doing that piecemeal? Marissa and Nina guide us.
This is Marissa. So this section that we're getting into are really the drug classes that have no big clinical updates. Or we did do a little something new where we're only mentioning the classes where there might be small drug updates. So it's like a quick 1-minute overview for some of these. But for the large part, a lot of them don't have any updates. So for, I guess, Nina's specific section, there's just some call outs that we wanted to make, specifically in the ulcerative colitis agents and multiple sclerosis. They're not very major updates, but we're just going to mention them just to be for completeness sake. So I'll let Nina get into that. And then after that, I will get into the actual Apple Health PDL so you can see what the statuses are of all of the drug products that fall within these classes. So as you can see, there's quite a bit. Might take me a little bit of time to just go through each class one by one. And then after that, we just have the motion, stakeholders, the motion, and then that should be it for the rest of the meeting. So
Great, thank you for that outline. So I'll let Nina take over and then Marissa. And let us know when we need to come back on camera if you could.
Okay, will do. So Nina, whenever you're ready to just go through your small updates, I'll display them here for you.
Okay, perfect. Thank you. So our first one is ulcerative colitis agent. So just one update. There's a discontinuation in October 2023 for Delzacol mesalamine. So FDA posted that AbbVie will discontinue Delzacol 400 milligram delayed release capsule, and it's generic. The generic version by Teva will still be available. And for multiple sclerosis agent, there was just an FDA communication in May 2024 indicating Cobaxone generics glutamine acetate. FDA alerted patient, caregivers, and healthcare professionals of labeling update for glutamine acetate injection products that include a new warning that using an auto-injector that is not compatible with a specific glutamine acetate injection product may increase the risk for medication errors, such as a missed dose or administration of a partial dose. The availability of optional compatible auto-injectors for each glutamine acetate injection drug product may change with time. The FDA will no longer update this information on their website, and patients can continue to confirm the compatibility of their auto-injector by speaking with their HCP, visiting the drug manufacturer patient's information website, or contacting the drug manufacturer for more information, or referring to the auto-injector labeling. And that's all the updates I have for you guys.
All right, and then this is Marissa, so I'll go ahead and get straight into the AHPDL review for these classes. Let me just get my bearings right. It's going to be a little bit of moving that I have to do. Okay, so the first one, let me put myself on camera. All right. So the first class that I will be going through with not a lot of updates is the antifungals topical. So this class is really where you'll see like the clotrimosols, miconazoles. There's just a whole bunch of different antifungals in here. As you can see, we do have quite a bit of mix in this. So we have some that are non-covered, we have some that are preferred. And then we also do have, it looks like, some non-preferreds in the mix. It's probably easier for me to just point out what is actually preferred in this class so you can see. That's probably going to be a little bit cleaner to go through. So I'll just go through them pretty quickly. We have a clotrimazole cream, miconazole cream, tolnaftate cream, same thing, clotrimazole, tolnaftate. We have some cyclopyrox. Looks like we have a shampoo, cream and suspension, solutions, more creams, more miconazole nitrate creams, and the list can go on and on. But I would say, just looking at our list, it's probably miconazole, clotrimazole. Do we have ketoconazole? We do have some ketoconazole, cream and shampoo, and nystatin. We have creams, ointments, powders. Apologize for the scrolling. And it looks like that is the gist of what are our preferred products for this class. So I'll go ahead. I know that was a lot. I'm just going to skip through, but feel free to stop me if you want me to go back to any specific class. The next one I'm going to go through is our antivirals, which is going to be our influenza agents and our smallpox agents. For these classes, for the preferred, we do have generic oseltamivir phosphate. So we have the capsule and the suspension preferred. We have a Rabivab preferred, Romantadine tablet. And then for the smallpox agents, we have Tembexa. That's the only product in the class that is preferred as well. Moving into our cardiovascular agents. So for this one, for sinus node inhibitors, transthyretin stabilizers, and vasoactive soluble guanylate cyclase stimulators. Wow, that was a mouthful. Everything is pretty much preferred in all of these classes. We do have PA. It looks like for the Corlanor and the ivabradine or the generic, we do have a applicable policy. But for the Vindamax, Vindaquel, and Vercuvo, we don't have any policies yet that we've created for those, but there is PA. Moving into our endocrine and metabolic agents, let me get into these. The acid and pituitary. All right. For the Fabry disease injectable, Fabry disease oral, fatty acid, metabolism agents, and pituitary suppressants, you can see that everything is pretty much preferred in all of these classes with PA. We don't have any applicable policies for them yet, but still have that PA on them for those. Getting into the gastrointestinal agents, I didn't list, well, actually here, I might not be on the agenda. So we have the inflammatory bowel agents and the irritable bowel syndrome agents, or GI motility. So for the inflammatory bowel agents, the preferred products in this class are, if it will let me click. We have balsalicide capsules, osalazine, we have mesalamine rectals and tablets. We have mesalamine, more capsules and tablets as well, the ERs. And then we have sulfasalazine tablets and DR tablets as well. For the irritable bowel syndrome drug class, for this, our preferred products are brand name Linzess, and then also generic lubiprostone capsules, and looks like this is Movantic. And there are applicable policies for the irritable bowel syndrome products. Then moving into our genitourinary for overactive bladder. For these, our preferred products are, we have generic bethanechol, generic festoteridine, oxybutynin, solifenacin, and brand name Toviaz. And those are pretty much all preferred without PA. Then moving into our hereditary angioedema agents. Our preferred products in this class are icatibant syringe and Kalbitor vial. Those are both injectables. And then for multiple sclerosis, for this class, we have Avonex syringe and pen injector, that's preferred without PA. We have Betaseron, which is interferon beta 1B, preferred. It looks like that's a kit. We have brand name Copaxone, generic dimethyl fumarate. We have Kesimpta pen, preferred without PA. We have Tesenso ODT, which is fingolimod lauryl sulfate. That is preferred with a PA. We don't have an applicable policy at this time. And then we do have the Zeposia, which is preferred with PA as well. So those are our preferred. Then for the neuromuscular agents, these two. Yeah. So for Friedreich's ataxia agents and Rett syndrome agents, we have Skyclarys and Daybue. For those, they're both preferred with PA. No policies yet as of this time. Then for some of the oncology agents, let me just get these. I apologize if you can hear the yard people outside. It's always good timing when you have a meeting, right? So for allogenic cellular immunotherapy, for that class, we have Omasurge or Omidubicel. That one I believe is a carve out. That's why it's included on our PDL. That's why it doesn't have a status, but it is included. It's probably most likely on medical with PA. for gonadotropin releasing hormone receptor antagonists. We have Orgovyx or Relogolix that is preferred with PA. For everything else, pretty much for interferons, LH, RH injectable, and urinary tract protective rescue agents, everything is pretty much preferred with PA, especially for the LH, RH injectables, so the Leuprolides, Lupron, Trelstar, Eligard, Finsolvi. Mesnex is the only product in the urinary tract. That one is preferred, and that one does not have PA. Then moving into our ophthalmic agents, which is cholinergic agonists and complement inhibitors. For these ones, this is for the cholinergic agonists, I should say, it's Trivia and Vuity. I hope I'm pronouncing those correctly. Those are preferred with PA. We don't have any policies yet. For the complement inhibitors, we have Izervay and Syfovre. Hopefully I'm pronouncing that one correctly. That one is a carve out, most likely. You won't see any preferred statuses as well, similar to what you've seen, but we do most likely allow it through medical. There's probably PA on that product. And then the last one is our vitamin D, which this can get a little confusing as well. So we do have various non-covered reasons. So sometimes we have non-covered OTC, and then we also have non-covered vitamin. So you might see that on our AHPDL, which you'll see here. But we do have preferred products that we do have in this class. So I'm going to try to call out the ones that we have. So we have cholecalciferol vitamin D3 drops. We have various ones here. We have calcitriol capsule and solution, various D3s that we have depending on the formulation, lots of drops and tablets and some capsules. We do have a vitamin D2, which is the ergocalciferol. We do have the capsule and tablet. I believe for the most part, it's mostly just D2 and D3 that lives in this class, but we do have some products that we cover for vitamin D. And I think that was it. I know I went through a lot. Let me know if you have any questions. I'll go ahead and open up the floor.
Go ahead, Peter.
Yep. Thanks, Peter Burkett here. I was wondering if we could go back to the overactive bladder agents for a second. I noticed that a few of the anticholinergic agents that have not been associated with cognitive issues were not on the preferred drug list. And I was wondering why, just because I think they're pretty inexpensive. And I think trospium was the one I had picked out in here. Like oxybutynin and some of the other anticholinergics have been associated with cognitive declines, but trospium is.
We talked about this before too, like a few months ago.
And then the one other thing that I noticed on this list, I think mirabegron is listed on here. It's now available as generic. And I wonder if that will end up at some point on the preferred drug list as a totally different mechanism of action, being a beta-3 agonist. I think it's still pretty expensive, even though there's a generic available, but it's a different mechanism of action that avoids that antimuscarinic pathway.
This is Marissa. So to answer your question about the mirabegron, we're probably still just keeping an eye on it. So we haven't really made any changes. I think it's kind of been a while, to be quite honest with you, since we have reviewed this class, just because I think in general, there hasn't really been very much that we've seen going on. So I think this is a good trigger to reevaluate it. So any recommendations that you have, I can definitely take back as we review this class.
In June, we did edits to the motion, I know, to talk about how we needed at least two of that were not. I remember us talking about this in the past. Am I going crazy?
This is Marissa. I'm gonna have to double check in June what that was looking like. So I'm trying to pull up the
Zoe,
motion.
I remember discussing it. You're
Yeah.
not going crazy.
Okay. Yeah, I remember having a whole discussion with Peter about how we needed to have two options besides oxybutynin, besides Myrbetriq, that were preferred.
This is Marissa. I don't see it in the list of classes for June that we went over for motions, unless it was another meeting.
It was probably P&T, rather than DUR.
Yeah, so that is a little different as far as for the P&T section. Yeah, it does look like in June you did go through that for the P&T section, which doesn't apply to our Apple Health.
So the decisions we make in P&T don't get reflected on this preferred drug list in terms of what's P and what's N?
No, they do not. That is,
Oh,
yeah, that's only for, correct me if I'm wrong. I don't think Ryan P is on the line. I believe that is for the Washington PDL, which is specific for LNI, and I think it's our UMP.
Okay, so I would just say it would be easiest probably to start from whatever decision we made there and have it match what our recommendation is here, rather than trying to come up with something new.
And I don't know that we can tell them what to hand we can only say like what is eligible, but I would strongly advocate for having a couple of anticholinergics not associated with cognitive decline on the preferred drug list, and then at some point considering whether to put mirabegron on the preferred drug list now that it's generic. I realize it's still more expensive, but and I think that might have to do with a branded generic. But when true generics are available and the cost comes down, then I really don't see a reason not to have mirabegron at that point on the preferred drug list.
Yeah, this is Marissa. So you as the DUR board are more than welcome to add recommendations to, I believe you guys may have done it before. In the motion, I can add like a little bullet here in the motion saying recommend adding a, I don't know, overactive bladder or what have you, product to the PDL without cognitive decline, something along those lines. You are allowed to do that as well.
Would Nanya have the language from June that we decided on already so that we could copy and paste that into this motion?
So this is actually what you all came up with at the meeting. It was a little different. So let me see. So I think a once daily formulation must be included as a preferred drug on the Washington preferred drug list. Of course, I only read that last sentence, but there's more. But this is what was voted on at that June meeting.
Thank you for pulling this up. That's exactly what I was thinking about. So something about trospium and darafenicin, maybe we could add up to this one, and then also that something similar to that last sentence.
Do we want to, Kavita here, do we want to take that sentence regarding the trospium and the darafenicin?
This is not we don't do therapeutic interchange
Right,
with
yeah.
PDL, so I think that's not relevant. What would be relevant is the last sentence.
We would want the once daily, yeah, I think the once daily thing, and then also though, if we can get at the thing
An
that Peter's
agent
talking
without
about. Yeah.
cognitive side effects would be something like that. Go ahead,
I
Peter.
think, yeah, I think I would include a line maybe that says at least two neuroselective anticholinergic agents, parentheses, e.g., darfenicin and trospium, other parentheses, should be included on the preferred drug list.
I agree with that.
Are those the only ones that are
Well, I think those are the ones that, like, chemically speaking, they should be neuroselective and they've not been associated with cognitive decline. There are, depending on which study you look at, there are some others that have not been associated with cognitive decline, like I think tolterodine and glycopyrrolate were looked at and they didn't see the cognitive decline, but it doesn't make sense why they wouldn't because they're not neuroselective. So it kind of depends on how confident you would
so
want to be.
I would rather you say formulations that are that are not associated with cognitive decline so that we can look at the evidence and then pick the least costly alternatives that do not have cognitive decline.
I'd be comfortable with that.
Do we think cognitive decline is the right term?
Yes, I think saying that an agent that is not associated with
Adverse cognitive outcomes, I think, is maybe what the urology language guidelines language is. Or cognitive impairment is another. Adverse cognitive outcomes I'm seeing in a lot of different papers. So maybe that's a way to put it.
Sorry, this is Marissa. I kind of was trying to listen and paste and do things at the same time. So I'm ready to wordsmith whenever someone is ready.
Okay, so at least a once daily formulation and must be included. Sorry, I'm going to remove the and, so it'll be a freestanding sentence, and then at least one agent that is not associated with adverse cognitive outcomes would have preferred status, or yeah. How's that look to the board?
We probably want to say at least one once daily formulation must be included. And then should it say included as a preferred drug on the HPDL for both? Okay, at least one agent is not associated with adverse cognitive outcomes. Must be can you add must be included as? Okay, perfect. And then I still would love to do something about mirabegron as well, though. I don't know if we can do anything about that here.
Any ideas, Donna?
I think, I mean, it's still, just because it's non-preferred doesn't mean patients don't have access to it through prior authorization and, looking at the cost. I think we would still want to try less costly alternatives unless there was a clinically appropriate reason to jump right to mirabegron.
This is Marissa. Yeah, it does look like the way that it is. I don't think it's listed here, but there is no PA on it, so most likely there's probably step throughs. I'm gonna assume it may be two. Don't quote me on that, but there's probably step through one or two to get to it. So it's not a full PA.
Okay. And then John, you also have your hand up.
My comments about the ATTR cardiomyopathy for the Vyndamax. Do you mind bringing that up?
Sorry, this is Marissa. I just want to make sure for this language for the overactive bladder, is everyone good for now? And then we can go back.
Looks good to me.
Okay, I will go ahead then, John, and skip over to yours. You said it was the Vindamax and the Vindaquil, right? I don't remember.
Correct. Yeah.
There we go. Okay.
So we administer some of these medicines for cardiomyopathy, and I was just wondering the Amvuttra, I don't see that in there. There's kind of two analogs that are frequently used. That's a healthcare administered med. I'm not sure if that's like a carve out, the Amvuttra.
This is Marissa. I will have to double check. Do you mind spelling that drug for me? I can actually, because
It's
this is not expensive PDL. Go ahead.
Amvuttra.
So that product actually lives in a different class on our PDL. It's called the Neurological Agents Transthyretin Amyloidosis Agents drug class. That one, it is included on the PDL, and we do have it just for reference as preferred with PA. We do have a policy for that, which is posted online. So you can reference that as far as any kind of clinical criteria for that, but it is in a different class.
Okay.
So that's why you don't see it.
Any other questions for Marissa?
This is Marissa. And also, sorry, John, to answer your question, the other product that you were referencing, the Amvuttra, that one is a carve out. So that's why it is probably separated from these products.
Okay, great. Thank you.
Mm-hmm.
Any other questions for Marissa? And if not, Nanya, do we have any stakeholders?
Hi. Sorry, I was trying to unmute myself. Let me see. I know we have our hands raised, but I think we had some stakeholders that um pre-registered, and let me see here. The first one I have is Sharon.
Oh, I see that. Shannon Payne.
Yes.
Hi there.
Yeah. Hi. Can you hear me?
Yes, we can.
Hi, I'm Shannon Payne. I'm speaking on behalf of BioCryst, and I'm neither a patient nor a provider. Thank you everyone for the opportunity to present to the board today. I'm Shannon Payne, and I'm your principal MSL at BioCryst, the manufacturer of berotralstat, brand name Orladeyo. In support of Washington Medicaid patients with hereditary angioedema, BioCryst asks the board for Orladeyo to be placed on the preferred drug list without barriers to access. Now, I'd like to give a brief update on berotralstat data, including guideline updates, confirmation of efficacy and safety, and importantly, new published data showing reductions in healthcare resource utilization following berotralstat initiation. Orladeyo was FDA approved in December 2020, becoming the first oral targeted agent for prophylaxis to prevent attacks of HAE in adults and pediatric patients 12 years of age and older. Orladeyo is the only oral first-line treatment and does not require additional supplies for storage or administration. Patients treated with berotralstat in the pivotal double-blind placebo-controlled APEX-2 trial experienced a statistically significant reduction in HAE attack rates compared with placebo at 6 months. Quality of life improvements were also seen. Newly published data shows that berotralstat also demonstrated continued safety and effectiveness over the long term. Patients on berotralstat 150 milligrams experienced a 90.8% average reduction in monthly attacks at 24 months. In addition to significant decreases in attack rates and improvements in quality of life, patients treated with Orladeyo in clinical trials also used fewer doses of rescue medication and treated fewer attacks after 4 weeks on Orladeyo. Newly published retrospective data using 2015 to 2022 administrative claims showed significant reductions in the overall rates of all-cause and angioedema-related hospitalizations after initiation of berotralstat. Orladeyo is generally well tolerated, with the most common adverse events seen being GI-related, graded as mild to moderate, short-lasting, and self-limited. Patients report fewer adverse events over time, and this is confirmed across clinical trials and real-world evidence. These data reinforce that Orladeyo is generally well tolerated and effective in reducing HAE attack rates, use of rescue medication, and other healthcare resources in patients with HAE. Today, Orladeyo is the only oral option for targeted HAE prophylaxis and is recommended in the World Allergy Organization 2021 guidelines as first-line long-term prophylaxis in HAE. Thank you for your time, and I'm happy to take any questions.
Thanks so much, Shannon. Any questions for Shannon? Okay, thank you. And then I see Mandy Champ listed.
Hi, thank you so much for the opportunity. I'm happy to give my time back to the committee.
Okay, thank you. Any other stakeholders, Nadia?
Linda?
Yeah, can you hear me?
Yes, we can.
So good afternoon. I'm going to speak first about Tysabri for the MS class, and then Skyclarys for Friedreich ataxia. Is that okay to go ahead and do it that way?
Yeah, that'd be fine. If you could please answer the questions on the screen real quick.
Sure. My name's Linda Finch. I'm speaking on behalf of Biogen. I am not a patient or a provider. So as I mentioned, I'll be discussing Tysabri today. So I have supported Tysabri along with Biogen's portfolio of MS therapies for over 17 years now. And over that period of time, there's been a significant shift in how MS is treated. And there's now a large number of therapies available to treat MS. But Tysabri remains a critical tool for neurologists, especially for rapidly stabilizing patients with highly active or aggressive MS, and for treating patients with MS-related cognitive impairment. Patients treated with Tysabri have experienced clinically meaningful improvements in cognitive tests. Risk mitigation strategies for Tysabri have also continuously evolved, and neurologists can now identify who is at highest risk of developing PML and reduce that risk through the use of tools such as JC virus testing, JCV index, and extended interval dosing, which has significantly reduced the risk of PML in JC positive individuals. During the COVID-19 pandemic, other attributes of Tysabri, such as the preserved response to vaccines and its mechanism of action, which doesn't deplete lymphocytes, have made Tysabri an essential first-line option amongst the high-efficacy therapies. MS therapies which deplete lymphocytes led to more severe COVID-19 infection and a higher risk of hospitalization. And therapies which impact the response to immunization, such as S1P inhibitors and B-cell depleters, present a real challenge and dilemma in our post-pandemic era where regular vaccine boosters are needed. Your current criteria require that MS patients fail 2 therapies prior to using Tysabri, and these criteria don't account for the heterogeneity of MS and that some patients do have aggressive disease early on, and they can sustain permanent disability with each relapse. And cognitive impairment can begin early in the disease course and can be even more disabling than physical disability. Patients with highly active MS can't afford to try and fail less effective therapies before stabilizing their disease. Failing a less effective therapy could mean that the patient has ongoing disease activity and could have some permanent neurologic disability. So while you may allow for medical exceptions, that does take time and a dedicated provider. And in MS, time loss equals brain cells loss. So there are national guidelines supporting the use of Tysabri as an option for early aggressive disease characterized by frequent relapses with incomplete recovery and the accumulation of focal lesions on MRI. And so I respectfully request that Oregon Medicaid follow these national guidelines for the treatment of MS and allow for the use of Tysabri as a first-line option for patients with highly active or early aggressive disease, including manifestation of MS-related cognitive impairment. So thank you very much for your time. I'm happy to take any questions. And if there are no questions, then I will go to the Skyclarys testimony.
Any questions for Linda? Go ahead, Linda.
Okay, so my intro is the same, and I don't have any other conflict of interest other than I am an employee of Biogen, the manufacturer of Skyclarys. So thank you for the opportunity to discuss Skyclarys. I know you haven't developed a policy yet, so my goal today is really to give you some key considerations in terms of developing a policy. So Skyclarys is the first and only treatment indicated for Friedreich ataxia, or FA, which is a rare progressive neurodegenerative disease that affects about 5,000 individuals in the US. For the sake of time, I'm going to refer you to the PI for warnings and precautions, and I'll focus on these key clinical policy considerations. So FA is a relentlessly progressive neurodegenerative disease. It leads to loss of coordination, lower limb movement, independence, and ambulation. And even after wheelchair dependence, this progressive multi-system disease continues to affect motor strength, reflexes, hearing, vision, cognition, and cardiac function, ultimately leading to death around age 37 on average. Untreated FA patients experience disease progression of about 2 points per year as assessed by the Modified Friedreich Ataxia Rating Scale, or the mFARS. And Skyclarys has been shown to slow down this progression. Patients treated with Skyclarys achieve statistically significantly lower mFARS scores compared to placebo at week 48 in the clinical trials, and slower progression out to 3 years compared to matched untreated patients from a large ongoing natural history study. I do want to share that while the mFARS is a validated neurologic assessment tool in Friedreich ataxia and is used as an outcome measure in registries and clinical trials, it's not really used in clinical practice, even by specialists. So FA is generally diagnosed and managed by pediatricians and primary care providers, and they're not familiar with this tool. It's a heterogeneous disease, and patients have a lot of variability in their disease progression and symptoms. So providers use specific neurological assessments to individually monitor their patients. So I recommend that you don't require the mFARS to monitor disease progression. It's not an appropriate tool for this purpose. It lacks sensitivity to change over short periods of time, and it was designed to evaluate FA at a population level, not individual patient level. It presents a barrier to patients due to the lack of provider familiarity, and it requires a significant investment of time. And it also isn't appropriate for assessing non-ambulatory patients since it's heavily weighted towards upright stability. We do know that individuals afflicted with FA can often maintain their upper body strength even after they require a wheelchair due to ataxia. So this is an important consideration when designing a policy, since maintaining upper body strength is critical for maintaining independence and quality of life. And non-ambulatory patients have shown benefit for treatment with Skyclarys. I think I'll end there and just request that you allow patients to receive Skyclarys. And then we recommend an initial authorization period of 12 months to allow sufficient time for response to treatment. We did see response to treatment by about 9 months in the clinical trial. And then if you can allow for repeated treatment if patients have shown a response to therapy by stabilization or slowing of the natural course of their disease. Thank you for your time today. I'm happy to address any questions.
Thank you, Linda. Any questions for Linda from the committee? Okay. Any other stakeholders, Nadia?
No other stakeholders have their hands raised.
Okay, then we can have a look at the motion.
This is Laura. I had one question regarding the MS agent. So for Tysabri, I was surprised to see that it was an N and not an X because it's primarily given in the clinic setting. So wouldn't it fall under different criteria?
This is Marissa. So we probably, let me see if we actually allow it through both. I would imagine we do. We may have had some experience where it came through either some type of infusion pharmacy or something like that. So that's why we usually would include that. Yeah, so we do allow it through both medical and pharmacy, and there's probably some type of experience we've had where it's been billed through some type of infusion pharmacy or whatnot. So that's why it does have a status for it.
Does anyone else have enough experience to know that there are like drugs on this list that should be preferred or that we should like argue about it all? Like I have patients on some of these, but I don't know how much the neurologist had to go through to get them or if there's any like I feel like with the urinary retention ones we had personal experience and with this one I just does anyone on the committee have thoughts about that?
This is Peter. So the last time I did a big overhaul of MS drugs for another health plan, the way that we had done it is we split it into moderately active and like highly active, and then made sure we had medications from each group. Kind of first glance over this, it seems appropriate, but I probably need to do some comparison against the rest of the market to confirm.
Are there any changes you would propose, Zoe?
No, not in particular. I don't know enough and I don't know if we have any neurologists so here. So I just, you know.
No, that's a good call out. Okay. So in the absence of that, other questions or changes to the motion? Okay. So then I am hearing that maybe the motion is okay to proceed with.
This is John McKay. I move that all products in the drug classes listed in slides 14, 15, 16, and 17 are considered safe and efficacious for their medically accepted indications, are eligible for preferred status and grandfathering at the discretion of the HCA. Products in these classes may require prior authorization to determine medical necessity. All non-preferred products require trial of at least two preferred products for the same indication before a non-preferred drug will be authorized, unless contraindicated, not clinically appropriate, or only one product is preferred. For the genitourinary agents, overactive bladder agents, at least one once daily formulation must be included as a preferred drug on the AHPDL. At least one agent that is not associated with adverse cognitive outcomes must be included as the preferred drug on the AHPDL.
Christy
This is
Weilander.
Michael Corsellis. I second that.
Great. All in favor, please say aye.
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 Any opposed or abstain? Okay, with that, the motion carries. And I think I see that it's the end of the agenda for today, Marissa. Nanya, am I missing anything?
This is Marissa. Yep, that is the end of our DUR agenda. So I'll hand it off to Nanya for any other logistics we need to go over.
An amazing job today, team. And I'm so proud of like how much we are also advocating for access to these treatments for our patients as with our clinical brains and also the clinical expertise on this team. But yes, go ahead, Nanya.
Yes, thank you guys so much for all the work that you guys have done today. With that, Kavita, it's your last meeting with us today.
Kavita, I just wanted to, thank you for participating in the P&T committee, DOR board, and for your leadership for this last year. And we will definitely miss you next month. And in the future. So thank you for your participation. We really appreciate all the work that you've done, and looking forward to working with you maybe in the future. If so, you should return.
Thank you so much. It's been such a privilege. And then again, I echo what an amazing team we now have. All of the advocating voices and so much clinical expertise in these 12 boxes here on my screen. So yes, thank you so much. It's been an honor.
Thank you. With that, there's no any comments or concerns or questions. If not, that's it for today, you guys. Thank you again. Thank you, Kavita.
Okay, we adjourn the board then.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye.
You.
Have a great day.
Bye. Thank you.
Bye.